you all her best wishes for the meeting. So you'll see her around and she'll try to join some sessions, but she has very difficult connectivity for unavoidable reasons. So she won't be as present with us this year as she was last. So let me introduce what she would have introduced, which is what we'll be focusing on for the next 3 days. The objectives are to provide a retrospective of this past year on yellow fever and eye activities, to gain an understanding of the achievements and challenges faced at country, regional, and global level, to share knowledge and experience, what we've learned in this past year, especially under the umbrella or under the cloud of COVID, and then also to agree on priorities for the rest of this year and into next year. So let's go to our first session, where we're actually going to start with a video. The first session is a global overview of the situation. So we'll see this video as well as have a presentation on the strategy. It's a short documentary that was done this year in the Democratic Republic of the Congo during the preventive campaign, the preventive yellow fever vaccination campaign. So let's have a listen.
Mama, papa, kisi ezali pour la lobiko. Soki ezali na mwana 9 mois, kobana 9 mois à 60 ans, ne kobolika mibokoza kisi na mikola lobi.
La fièvre jaune, c'est une maladie virale causée par un virus amaril. C'est une maladie qui est endémique, surtout en Afrique et en Amérique latine. Il se manifeste par une fièvre qui apparaît parfois brusquement. Ça peut se compliquer par une hémorragie et puis la mort peut s'en suivre. Et jusqu'à l'année 2015, presque toute l'Afrique de l'Ouest avait déjà été couverte par des campagnes de vaccination. Jusqu'à 2016, où on a connu une épidémie la plus grave qui avait attaqué l'Angola, importée en RDC. L'OMS, l'UNICEF et Gavi ont dit encore non, qu'il faudra encore créer une autre initiative. Et cette initiative, on appelle ça la stratégie I, Eliminate Yellow Fever Epidemics. Et c'est grâce à cette stratégie et beaucoup d'autres organisations internationales, telles que PATH, qu'aujourd'hui, les campagnes préventives sont programmées dans tous les pays qui, jusqu'aujourd'hui, n'ont pas encore organisé de campagnes de vaccination.
Nous sommes à la deuxième campagne, en l'espace de 5 ans. Celle de 2016, effectivement, on a eu à adapter les stratégies dans le contexte de la pénurie de vaccins anti-amaril. Et c'était une des premières expériences où on utilisait les doses fractionnées. Et c'était sur la recommandation de l'OMS. Et en 2021, nous étions en train de mettre en œuvre cette campagne. On l'a préparée déjà dans le contexte où le monde faisait face à la pandémie de coronavirus. Cette pandémie a d'ailleurs retardé la mise en œuvre de la campagne telle qu'initialement prévue.
En dehors de ces reports, il y a aussi les coûts sur le plan financier. Il a fallu qu'on puisse augmenter les budgets pour la campagne, d'autant plus qu'elle doit se dérouler dans le contexte de la pandémie Covid, et où on doit respecter toutes les mesures barrières, ne pas contaminer les acteurs et que les bénéficiaires aussi ne soient pas contaminés.
C'est pour nous une très très grande réussite. Il y a d'abord eu appropriation de la stratégie de l'initiative de la part du gouvernement. Donc le PEV réunit tous les partenaires pour assurer une coordination assez forte entre les différents partenaires.
Pour cette campagne de vaccination contre la fièvre jaune, nous appuyons le gouvernement particulièrement dans les domaines classiques tels que la logistique avec le transport des intrants. Nous appuyons également le gouvernement dans la sensibilisation.
Nous travaillons avec les équipes locales. On préfère identifier les personnels localement pour qu'ils fassent le travail, qu'ils connaissent bien les milieux.
Et il y a des zones difficilement accessibles. Je me rappelle même des camions qui transportaient les intrants pour amener dans une zone d'accès difficile. il a fallu une semaine pour que les camions puissent atteindre la route. Et il y a dans certaines zones de santé, dans certaines aires de santé aussi, des endroits où ni moto, ni vélo ne peut circuler. Alors les vaccinateurs sont parfois obligés de parcourir de longues distances en pied afin d'atteindre la population, ce qui n'est pas aussi facile.
Le plus grand défi qu'on a rencontré sur le terrain, c'est plus par rapport à la capacité de stockage, du fait que dans le coin, il y avait un problème par rapport au matériel de chaîne de froid.
L'équipe que vous voyez là, nous nous apprêtons déjà à aller vacciner de l'autre côté de la zone de santé de Lubunga. C'est une zone de santé urbano-rurale. La population semble être un peu réticente, mais avec la sensibilisation, nos réseaux sont en train de fournir beaucoup d'efforts pour convaincre cette population parce qu'ils contestent. Pour la population, ils croient que c'est la vaccination contre la COVID-19.
Nous avons mis en place une stratégie de communication, une stratégie de mobilisation et engagement communautaire qui nous a permis de faire comprendre à la communauté que réellement c'était le vaccin contre la fièvre jaune. Et quand la population a vu que les leaders, les chefs sont vaccinés, ça a permis quand même que la population adhère à cette vaccination.
Donc, on a le vaccin à la fièvre jaune, on a une fois la vie, donc, sur la PCO ici, aux gens sautés. D'ailleurs, on a
Pour une meilleure appropriation de la stratégie AI en RDC, il faudrait mettre en place ou disponibiliser des ressources pour le bon fonctionnement du programme élargi de vaccination. Par exemple, la création d'une ligne budgétaire qui est dédiée aux activités de routine, de vaccination de routine, qui permettrait au programme d'acquérir le matériel nécessaire et même de retenir le staff au niveau national, mais également au niveau provincial.
Il y a des stratégies qui ont été montées, dont cette campagne de vaccination des masses qui a vu Gavi intervenir, OMS, UNICEF et tous les autres partenaires techniques et financiers qui ont mis la main pour nous apporter un appui technique, un appui financier. Et que si aujourd'hui nous sommes en train d'aller vers la réussite, c'est que ces partenaires-là se sont mis ensemble, ont mis les moyens et le gouvernement aussi s'est impliqué. Et aujourd'hui, nous sommes en train de relever ces défis.
On a une histoire des victoires sur certaines maladies. Je rappelle ici la victoire à laquelle nous avons participé sur l'éradication de la variole. La RDC, depuis 2020, est certifiée avoir éliminé le tétanos maternel et néonatal. Ça a été une des grosses luttes aussi dans le pays. Donc, fort de ces expériences, et fort aussi des résultats que nous sommes en train d'atteindre avec le renforcement de la vaccination de routine, parce que c'est la base et le socle de toutes les activités de vaccination. Je suis confiante qu'on va vraiment arriver à éliminer la fièvre jaune en RDC, quoi qu'on soit un pays à risque.
Thank you. Thank you to those who put together that video, but especially thank you for the colleagues who are doing that work. I think the video really illustrated those challenges very well. So the next part of this session is to give you an overview of the strategy. And just to say, there may have been some audio troubles for some people, and I apologize for those glitches. The video should be available to you to watch separately if you wish later, and we're trying to iron out any other difficulties as we prepare for the next session. So this next session would normally have been presented to you by Laurence Sibrelus in person, but because of her bad connectivity and the unavoidable challenges there, we're going to have her voice over the presentation, which she's pre-recorded for you. And remember, if you have any questions, we'll have a Q&A session after this with a couple of technical colleagues from the iSecretariat available to handle questions. So do download the app and drop your questions there. So without further ado, as they say, let's go over to Dr. Laurence Sivelus for her presentation on the Global Eye strategy over the past year.
Good afternoon, good morning. We meet as partners for the 5th time to take stock of what we accomplished as a community, of the challenges faced, of the emerging risks, opportunities, and priorities, and to jointly define where we should go next to fulfill the commitments we made in 2016 and 2017. On the next slide, the numbers we see speak for themselves. Since the eye launch in 2017, more than 180 million people in Africa have been protected for life against yellow fever by a single injection, with the 2021 estimates being preliminary. Details on numbers and geographies are highlighted on the slide. Our ability to prevent yellow fever on such scale is closely linked to the unprecedented sustained scaling of yellow fever vaccine production, with a supply available for prevention in Africa and for emergencies that multiplied by 1.7 to 1.9 between 2017 and 2020 and 21. This was made possible by yellow fever vaccine manufacturers who are integral to the partnerships, and by the UNICEF and Gavi partners steering the market shaping, forecasting and procurement efforts via the Eye Demand and Supply Working Group. The group is also developing better multi-year campaigns forecast, which is critical as we, countries, regions, and partners need to ensure that the supply provided in response to the needs we laid out is fully used. We will hear about the PAHO specifics on these issues and the emerging priorities in their regional address later on. On the next slide, we see that we prevent more and we also prevent better because we have tools to ensure risk-informed decisions are made with goal to allocate vaccines where they could have the larger impact on risk with a regional perspective at the moment, and where they have the greater likelihood to be used. These risk analysis and prioritization tools are developed by the Eye Risk Analysis Working Group steered by the US CDC. We are also implementing synergistic activities with other diseases such as measles or meningitis. These joint interventions are efficient, they ensure prioritization and optimization of resources, and fully aligns with the principles of the Immunization Agenda 2030, the IA 2030. The partnership is working to optimize data flow towards systematic tracking and consolidation of epidemiological and laboratory data. This is a multi-disease, multi-partner, long-lasting effort, all the more complex for yellow fever, given its unique position as epidemic-prone, vector-borne, IHR, and vaccine-preventable disease, with implication for surveillance approaches. The next slide is highlighting that we also have better ways to track Albrecht's end-to-end processes, which is proving helpful to identify where the gaps are and where we could make a difference. On this chart, note some key areas of challenges and delays faced during the first year of the pandemic and the disparity among requests. We also see key elements emerging that we are working to address: raising awareness for faster decision-making, increasing knowledge and providing resources and tools to strengthen Albrecht's investigation, building capacity, and I really want to highlight the increased laboratory capacity at national and regional levels with marked reduction in confirmation time. These efforts which are undertaken via the Laboratory Technical Working Group, co-led at the moment by the National Institute for Public Health and the Environment in the Netherlands, the Robert Koch Institute and WHO have taken a new dimension since the Gavi Yellow Fever Diagnostic Initiative. The bottom line is that it is data, information, and feedback from regions and countries that are driving us. As we are approaching the halfway mark of the strategy, it is important that we stay grounded, action and impact-oriented, and geared towards supporting regions and countries, with countries leading the charge and owning the I strategy. This is very much the vision behind the country and region twinning we'd like to implement to foster peer-to-peer learning and country collaboration across the 3 regions affected by yellow fever in order to build knowledge and capacity. These outbreaks timelines are also a strong reminder of the importance to manage yellow fever urban risk, as we will discuss later. As in urban context, all the components of the outbreak response cycle need to happen on an accelerated pace. We made impressive achievements since the I inception, and on the following slide, I would like to take the time to appreciate and thank you for the fruits of our collaboration and the impact on the investments made. As highlighted on the next slide, however, we are facing 3 critical risks with potential to derail the program and to jeopardize the major public health investments, efforts, and gains made since 2017, the inception of I, and even 2006 with the Yellow Fever Initiative. These risks are of particular relevance for Africa and will be the focus of my presentation. On the next slide, there is active yellow fever virus circulation in low immunity, high vulnerability areas across wide geographic distribution, leading to a high number of outbreaks across wide geographies, of which some are large and disruptive, per the IA 2030 definition. The outbreaks and virus circulation predominantly affect vulnerable countries and communities, which is aggravating risks, along with the delayed investigations and implementations. These delays are linked to a variety of causes, including the polio ramp-down, as we will hear from regions and countries. And they are a concern in the broader context of yellow fever shifting epidemiology, and also as border areas and mobile populations are affected with a risk of spread. Population movements are also towards urban centers, which remain largely unprotected as effort focus on protected populations at the source of the disease to avoid spillover and those potential introduction urban settings. This is a particular concern in Nigeria, where the yellow fever virus circulation is getting increasingly closer to Lagos. Urban outbreaks are disruptive, amplify and spread quickly. They also have the potential to absorb the supply available and to derail preventive interventions over extended time, as happened after the 2016 Angola and DRC outbreaks. This is why yellow fever urban risk management, with the development of yellow fever preparedness, readiness, and response plans, is critical until cities are fully protected. And this is a key contributions that the I strategy can make to the global arboviral initiative. Next, we are looking at delayed campaigns and other preventive activities leading to persistent risk. Last year in Nigeria, outbreaks were confirmed in states where preventive campaigns had been delayed by a few months, but which in turn could be leveraged as outbreak response. This year, there is also an example in DRC, with 1 confirmed and 2 probable cases within a family notified just before the implementation of a preventive campaign which had been delayed in the COVID context. All the supply available in 2021 is fully allocated, but we are feeling a marked impact on yellow fever prevention of the COVID vaccine rollout and competing priorities, with activities experiencing challenges and delays. For instance, part of the campaigns in DRC and Nigeria have been deferred to early 2022, but we will hear the latest updates from countries. The initiation of preventive activities in Guinea-Bissau and Ethiopia has also shifted by a year. The risk in Ethiopia is not to be underestimated. Examples from yellow fever history have highlighted that areas at risk for yellow fever remain so, and that some of the phenomena considered as emerging has actually happened in the past, as is the case for coastal yellow fever virus circulation in recent years in Brazil. Ethiopia has history of the largest yellow fever outbreaks in the African continent. It was in the 1960s, with an estimated 100,000 infections and an estimated 30,000 deaths. Ethiopia also saw recent virus circulations in areas without recent history of virus circulation, as well as Aedes-borne diseases outbreaks, including in urban settings. Finally, as reflected on the next slide, the majority of countries with history of preventive campaigns completed via the Yellow Fever Initiative have had routine immunization coverages insufficient to sustain the gains, with a downward trend in coverages over the last decade. The resulting accumulation of susceptibles has led to the resurgence of yellow fever outbreaks in some of these West African countries, such as Guinea and Senegal. In these countries, the local coverage estimates were much lower than the winning ones. This resurgence is linked to a combination of broader immunization performance issues and of yellow fever-specific ones, with the latter needing to be characterized and acting upon, as we will hear from the yellow fever and the eye vaccine delivery working group. The immunity gaps have worsened in the COVID context and could lead to further outbreaks. The next slide highlights similar concerns without actual resurgence at this time, and some Central African countries with recent yellow fever virus circulations and alerts. They also experience vulnerability and insecurity issues. In these countries, for example, as Cameroon and the Central African Republic. But the issue of outbreak resurgence in countries with history of preventive campaigns will not be addressed by the current campaigns and routine immunization introduction plans, as they concern countries without campaigns history. We need to define strategies that are decisive and efficient to preempt outbreaks in the high-risk countries where campaigns were the first implemented due to the high levels of yellow fever risks. These strategies need to be tailored to the specific vulnerability of these countries via, for instance, provision of bundled services. Opportunities also exist via the IA 2030, as not all issues are yellow fever specific. But defining these strategies is time sensitive from a yellow fever risk standpoint. Next slide. Yellow fever prevention and control is entering a critical phase. We can expect more outbreaks in more countries, including with history of previous campaigns. We need to anticipate them, to build capacity, and to ensure outbreak preparedness. Outbreaks also need to be more systematically used as opportunities for health system and coverage strengthening, seeking synergies across outbreak-prone diseases. To address emerging and re-emerging yellow fever risks, the eye partnership needs to continue preventive efforts on accelerated pace with synergistic vision. To address the resurgence of yellow fever outbreaks in areas with history of campaigns, with pragmatic, efficient, time-sensitive, and risk-prioritized strategies to close immunity gaps and ensure equity. We will define those together and seek synergies there too. To the specific used as a holistic vision. To address the resurgence of yellow fever outbreaks in areas with history of campaigns, with pragmatic, efficient, time-sensitive, and risk-prioritized strategies to close immunity gaps and ensure equity. We will define those together and seek synergies there too.
I think we're having some connection problems or some video problems at the moment, colleagues. Please stand by as we try to fix. I presume I'm not the only one with the frozen screen, so just give a couple of minutes for our colleagues to try to sort this out. Otherwise, we may move to the next session since our time is about right as well. Just hang on, we've got some, we're messaging each other behind the scenes just to see what to do next. In the meantime, if you look in the chat on Zoom, you will see the links to download the app either onto your computer or onto your phone or other device. It takes a few steps. You have to download the app and then sign in, and then you get sent a code and so on. So it takes a little bit of time, but it is our preference because it's a nice system. Our preference is to take questions and to have discussion on that app. If you're having trouble, a lot of trouble accessing it, then drop us a note in the chat. Still discussing the technical issues here. Please stand by. And also a reminder that there's a square for there's an icon to choose interpretation at the bottom right-hand side of your Zoom screen. There's a globe and there's a button for interpretation, and then there's the languages you can choose. I think there's been a little bit of trouble there as well. It's just the growing pains when you start another meeting. Even though we're this far into COVID, we still have this far into COVID and online meetings. We still have these challenges sometimes. All right, I think we're going to move to the next session. The next session is session 2 is yellow fever detection and control in the COVID-19 era. I'm sorry if you hear some noise on my line as well. We're going to have 4 speakers. We're going to have Dr. Mike Ryan, who heads the WHO Emergencies Program. We're going to have Dr. Ibrahima Sosé Fall, the Assistant Director General for Emergency Response. We're going to have Dr. Chikwe Ihekweazu in his capacity as Director General of Nigeria CDC, and Dr. Tahiru Diallo, a health worker from Guinea. A couple of the people in person, a couple of the people in video. So let's start with Dr. Mike Ryan, who's joining us by a video. He couldn't come to be with us today, where he will speak about lessons learned from the COVID-19 pandemic. Over to Dr. Ryan.
Dear colleagues and partners, it is an honor to have the opportunity to speak with you today. I would like to start by thanking the key partners of the Eliminating Yellow Fever Epidemic Strategy, UNICEF and Gavi, for the exceptional collaboration and partnership since its inception in 2017. The I strategy has exemplified how much can be achieved through partnership. Thanks to the EYE strategy, over 145 million people have been protected against yellow fever through vaccination campaigns. However, the last 22 months have been a challenge for us all. The global yellow fever response has not been spared from the secondary impacts of COVID-19. We have seen major disruptions to health systems worldwide, which have affected routine immunization and vaccination campaigns, especially in high-risk countries and regions. In 2020, 23 million children missed out on basic childhood vaccinations through routine health services, which amounts to an increase of 3.7 million children compared to 2019. The first 6 months of 2020 reflected a decrease in the number of yellow fever samples tested as well. Laboratories across the world flagged that in some instances RT-PCR reagents were diverted to support the surge in COVID-19 testing. Our Assistant Director General for Emergency Response, Dr. Sose Fall, will speak to you today in more detail about our programme's strategic vision for EYE, our key challenges, achievements and objectives. Dr. Chikwe Iwezu, who will soon join our programme as Assistant Director General, will also lay out the importance of global surveillance detection and investigation. I've been asked to reflect on a few key lessons from the COVID-19 pandemic, which could be of value and importance to the EYE partners and strategy. It needs to be said that the learning has been mutual. Your work and experience in the area of equitable and needs-based production and distribution of vital vaccines has in many ways been a trailblazer for initiatives such as COVAX. If there is one insight we should all take away from COVID-19 experience, and which is of critical importance for the successful attainment of EYE's strategic objectives, is that we will not improve health emergency preparedness and response unless we fundamentally recognise that epidemics begin and end in communities. The community is the front line. Therefore, global protection systems must be based on strong community-based surveillance and detection and response. It must be connected to the national public health systems, and national public health systems have to be connected to an unbreakable chain of global protection. This pandemic has taught us many hard lessons. It has exposed our inequities and vulnerabilities. It has exploited our interconnectedness. It has exhausted our often complex and rigid national and global systems. We have learned that too much complexity is an enemy in a crisis. We have learned that even strong health systems failed because they were not instinctively responsive and did not have the resilience, agility, and adaptability to absorb shocks. We have learned that the epidemic of misinformation can be equally as dangerous as a pandemic virus. However, this pandemic has also presented us with opportunities. We have learned that we can be innovative, creative, cooperative, and fast when faced with a crisis. We have learned that science can overcome politics. We have learned that communities are resilient and powerful. COVID-19 is hopefully also forcing us to rethink long-term sustainable health financing and to recognize that this is a strategic investment and not a cost. It has demonstrated the need for a stronger, better supported and protected health emergency workforce and better surveillance at all levels. It has demonstrated the importance of equity in access to life-saving vaccines, therapeutics and diagnostics. While recognizing EYE's remarkable achievements since 2017, the work is not yet done. The resurgence of yellow fever outbreaks in areas with a history of large-scale preventive mass campaigns underlines the need to enhance yellow fever prevention and control through the EYE strategy. Suboptimal routine immunization performance for yellow fever continues to be a global challenge, accelerating efforts to understand yellow fever's specific challenges and to take action to boost and sustain high population protection through routine immunization are of great importance. We all know that the success of eliminating yellow fever epidemics depends on effective early detection of yellow fever cases and active comprehensive population protection. Sensitive and responsive national yellow fever surveillance systems with linkages to global yellow fever laboratory networks will help us to ensure that any yellow fever outbreak can be rapidly detected. For example, we continue to face challenges such as the lack of dedicated in-country transportation system for yellow fever samples and an often lengthy turnaround for the results. Other drivers such as climate change, rapid urbanization, and the increased mobility of people and information offer both challenges and opportunities to prevent future epidemics. Urban yellow fever outbreaks are an increasing threat but through comprehensive preparedness, readiness, and response activities oriented for effective communities, these risks can be countered. By working together and building on the momentum, the strategic objectives of the ICE strategy for the elimination of yellow fever epidemics can be achieved by 2026. We need to protect the at-risk population, prevent international spread, and contain outbreaks rapidly. We must also link this work to the broader efforts to prevent and control other arboviral diseases for which many of the drivers are the same. I personally thank you all for your work, and I wish you a successful meeting.
Thank you, Dr. Ryan. Some of you may be having the same challenge. Thank you, Dr. Ryan. Some of you may be having the same challenge where there's a bit of noise on the video. All the materials, Laurence's presentation, the DRC video, the documentary that we saw earlier, they should all be available to you in the app. And I think some of the links have been dropped in the chat as well. But anything you want to see, we hope to make sure that you can see it. Just a reminder that we do have interpretation on the bottom right-hand side of your screen. You can click to choose English, French, Portuguese, Spanish, or Arabic. Let's move right on to the next presentation. We have with us in person this time, Dr. Ibrahima Sosé-Fall, who's the Assistant Director General for Emergency Response at WHO. And as Dr. Ryan indicated, he'll give us a bit more detail and take us through his vision for I. Over to you, Sosé.
Thank you, Nika. Good morning, good afternoon, good evening, colleagues and friends. I will give part of my presentation in French to make the interpreter work and to be more democratic, and I will finish in English. Donc, merci beaucoup. C'est un plaisir d'être encore avec tous les collègues et partenaires pour cette réunion annuelle extrêmement importante de l'initiative AIRE. Bien que la réunion soit encore virtuelle cette année, c'est une grande opportunité donc d'avoir tous ces participants, tous ces partenaires ensemble pour passer en revue nos progrès, revoir nos défis et nous accorder sur les priorités pour cette année à venir. Et aujourd'hui, je veux vous rappeler encore que l'initiative est une haute priorité pour l'OMS. C'est pour cette raison que vous avez aussi bien donc, Laurence Magren et moi-même pour faire ces mots introductifs. Et donc, pour montrer que la lutte contre la fièvre jaune est une priorité extrêmement importante, si vous revoyez juste le rapport du comité régional de l'OMS pour l'Afrique sur la revue, la sécurité sanitaire et les urgences, la fièvre jaune apparaît parmi les 5 top priorités. Et quand on regarde même les analyses sur plusieurs années, comme l'analyse des risques des épidémies que nous avons effectuées, les arboviroses en général donc, viennent à la 3e et 4e position, si on retourne même jusqu'à 40 ans, pour montrer que c'est vraiment une priorité pour l'OMS. Donc, avec la stratégie AIRE, nous avons une opportunité unique de travailler de façon intégrée pour avoir le maximum d'impact au niveau des zones qui sont le plus à risque. Et nous avons vu déjà beaucoup de résultats, donc en termes d'engagement des partenaires, mais aussi en termes de système d'approvisionnement, que ce soit pour les vaccins, pour les équipements de laboratoire et autres, malgré donc, les contraintes liées à la pandémie COVID-19. Et donc, je pense que Laurence a parlé déjà des résultats donc, obtenus en Afrique avec plus de 145 millions de personnes protégées à travers la vaccination de masse et depuis la mise en œuvre de l'initiative et aujourd'hui à 40 millions de plus qui sont attendus en 2021 en termes de protection. Donc la stratégie est une stratégie donc, collaborative et qui s'intègre et qui intègre d'autres initiatives qui existent telles que l'agenda 2030 donc pour la vaccination, mais aussi la nouvelle initiative donc, globale d'intégration des arboviroses. Je pensais c'est une opportunité pour maximiser l'impact au niveau des populations qui sont exposées à ces mêmes maladies. Nous avons vu aussi des succès importants entre 2020 et maintenant. Et juste quelques exemples, le Soudan a introduit la vaccination contre la fièvre jaune dans l'ensemble du pays dans ce contexte de Covid aussi. La République démocratique du Congo qui a lancé la campagne préventive en 2021 et qui a aussi organisé des investigations approfondies pour comprendre la dynamique de la transmission dans un contexte à haut risque. Le Ghana qui a fini la phase donc, de campagne nationale en 2020. Et nous avons vu aussi le Nigeria qui a eu à faire face à plusieurs épidémies de fièvre jaune jusqu'en fin 2020. Le Venezuela qui a mis en œuvre une série de vaccinations ciblées. Le Brésil qui continue à mettre en œuvre un système robuste de surveillance donc basé sur les cas, y compris chez les primates non humains, et un système de surveillance active pour éliminer la maladie à la source. Donc, sur le plan technique aussi, l'approbation de l'approche de l'analyse du risque avec le groupe de travail des experts a été un élément extrêmement important. Nous avons vu aussi des progrès importants au niveau d'un site de laboratoire avec le réseau et l'expansion de la collaboration entre l'UNICEF et le Gavi, mais aussi la disponibilité de plus de tests de laboratoire, y compris l'introduction de tests de diagnostic rapide. Je pense que c'est un élément extrêmement important. Et sur le plan des innovations, nous avons vu aussi des progrès importants en termes de délai entre le prélèvement des échantillons et les délais pour avoir les résultats. On est passé de 3 mois en 2017 à moins de 6 semaines en 2020. Je pense que c'est extrêmement important. Donc, ces progrès importants ne nous empêchent pas de regarder face les challenges et les défis qui existent encore. Et nous avons tous vu donc, les interruptions qu'il y a eu en termes de surveillance, mais aussi de prévention dû à la pandémie de COVID-19, l'accroissement important de la population à risque. Donc, même dans les zones où il y a eu des campagnes précédentes, je pense que c'est un élément important. On a toute une cohorte de population, une population plus jeune qui n'a pas été couverte par ces campagnes de masse, mais aussi donc, une stagnation au niveau de la vaccination de routine qui fait que ces populations donc, sont à risque. Si nous devons faire donc attention et travailler ensemble pour combler ces gaps afin d'atteindre les objectifs qui nous sont fixés dans le cadre de cette stratégie. In terms of capacity building, the AI strategy continues to support building of yellow fever control community to raise awareness on yellow fever control, and there have been enhancement of communication, including the launch of the AI podcast available across common platform, regular newsletters, and updates. In addition, our partnership is committed to development of improved learning strategy, and we are also using, online platform like OpenWShow, webinar, but also in-person, face-to-face workshop for the laboratory component. So there have been also development to support rapid country on detection and response. For example, leveraging the Go Data platform with our GONE partners, which is an innovative outbreak investigation tool for field data collection during public health emergencies to support yellow fever investigation. So we have field tested Go Data with Ebola first, with COVID, and now with yellow fever. I think this is an interesting development. So during this meeting, we look forward to learning from the 3 regions in which we operate, the African region, Eastern Mediterranean region, and the Americas. So we look forward to learning from our African counterpart, including Guinea, Sudan, DRC, on their successes and challenges, especially regarding the unprecedented outbreaks that have been experienced and in protection to the population through preventive and catch-up vaccination activities. We anticipate with interest the update from the AI Strategy Working Group on the progress made in technical assessment, operational support, and extension not only of immunization activities, but also capacity for surveillance and diagnosis. This session will offer opportunity to develop a plan on how to advance the next year of work, advance innovation and research agendas, and strengthen action toward elimination of yellow fever epidemics. We expect that engagement through the collective partnership and yellow fever community will revitalize and support acceleration of commitment and actions towards the objective. This forum provides us an unmatched opportunity to review and update on progress toward eliminating yellow fever epidemic globally under the air strategy. The contribution by all over the past year have been impressive. I would like particularly to recognize the great achievement of countries implementing yellow fever control activities, making great progress toward eliminating yellow fever epidemics. So looking forward to learning from each other through the course of the meeting and determining how to capitalize on the time also our implementation with a strong country orientation. Thank you very much, Nick.
Merci, Dr. Fall. Still encouraging colleagues to download the app and drop any questions you have either through the online version or through the app so that we can have some discussion. Next, we have, actually, I just wanted to mention, for those of you who don't know it already, we have an Eliminate Yellow Fever Epidemics podcast, which Dr. Fall, who you just saw, has participated in, Dr. Mike Ryan, our upcoming speaker, Dr. Chikwe Ihekweazu, and others as well. So we'll mention that as we go. The episode that has Dr. Ryan in it, we'll drop the link into the chat so that you can see that. So one more presentation on video. This one is this next one is Dr. Chikwe Ihekweazu, who's the outgoing Director General of the Nigeria Center for Disease Control. He's going to be joining WHO shortly, as Dr. Mike Ryan mentioned as well. And he will speak today, actually, he's speaking today on the experience in Nigeria and their challenges at the moment, their journey forward. Over to him now.
Hello, colleagues. It's great to be here and to present to you some of the work that we've been doing at the Nigeria Center for Disease Control and in Nigeria more generally on yellow fever. The title of this talk is titled Faster Yellow Fever Outbreak Detection, Investigation and Response, but it's really to describe the progress we've made in the past 5 years in this very important meeting of the Annual Partners Forum. So, you know, working in a country of 200 million people with the circumstances that we face, our socioeconomic circumstances, our climate, you know, we've been faced with a large number of outbreaks in Nigeria over the past many years. And this has been, you know, almost a microcosm of what is happening in the rest of the world. But the outbreaks that we shouldn't really be having anymore, one of which is yellow fever, and which is why we're all gathered today to think and talk about this and look really how to push ourselves to achieve more progress faster to getting this disease under better control in our world, but more importantly, at least for us in Nigeria and on the African continent. And like you can see from the clips on this slide, you know, this has been a recurring topic, not only for us health professionals, but for the general public in Nigeria. So where did our journey, our story really start? You know, for many years, we hadn't reported a confirmed case of yellow fever in Nigeria, whether that's because our surveillance was so poor that we couldn't detect one, or really that there wasn't any circulating, is up for discussion, but it's much more likely to be the first scenario. So in 2017, as we started strengthening our systems, looking a little bit harder, we found the first case in over 20 years. And at that time, really there was no confirmatory capacity in Nigeria. All samples had to be shipped off to the IP Dakar. We thank them very much for the support they have provided for us for many years in the confirmation of yellow fever. But it was really an embarrassing situation for a country of Nigeria's significance to be sending our samples across thousands of kilometers for confirmation. And that then also led to very serious challenges around control efforts, because it took a while to get samples out, get them out in the shape they needed to be, and get results in to then trigger a public health response. The public health response architecture was very immature. We didn't have EOCs in most states. Reporting systems themselves were manual and sluggish, and we really had poor guidelines to guide our response generally, not to talk about the poor vaccination rates that then lead to the emergence of more infections. So really a difficult situation to be in. So when this first case was detected in 2017, since then we've been detecting cases almost throughout the year in different parts of the country. So this really goes to show that the more likely scenario that there was transmission happening prior to 2017 in Nigeria. Most cases were found in the southern parts of Nigeria. Since then, since July 2017, we've found just under 700 confirmed cases, but over 14,000 suspect cases. The map just shows the distribution of cases. It's not really a gradient, so maybe the color coding is not appropriate, but these are the states reporting new cases in the different years from 2017. And of course, since then, we've been carrying out preventive and reactive vaccination campaigns in response, and therefore Nigeria now is a priority country in the yellow fever elimination strategy. So this is kind of just shows the distribution of cases this year alone from January to September 2021. We have 1,518 suspected cases with 39 confirmed so far. And like you can see, the distribution really mostly in the southern parts of the country, with the northernmost case being found in Niger State. We've had two deaths among confirmed cases, but with this number of suspected cases, and really the cloud of COVID that has kind of covered the public health space over the last year or more. You know, it may have been a little bit different to detect all the cases, difficult to detect all the cases circulating. In this slide, on slide 6, you really see the epidemic curve in months over the past 5 years. And, you know, you can see a very interesting trend of cases happening, really starting from middle of the year, May, June, and lasting to the end of the year in our Nigerian context. And these cycles have been fairly consistent. Like you say, the number of cases for 2021 is a little bit lower than we've seen in previous years. Highest number of cases were in 2020. So you can see that the trend in cases and the cyclical pattern is very similar across the years, even when we don't have that many cases being reported. So I think the most important point in my short presentation today is really to reflect a little bit on what has changed in the 5 years, for the past 5 years on yellow fever in Nigeria. I think the most important change and the driver of everything else is the building and the emphasis we've placed on the development of in-country laboratory diagnostic capacity. You know, we have pushed very hard for PCR to be accepted as a confirmatory test for yellow fever. There's no scientific basis why it should not be. And we're very glad that that has finally been agreed to by WHO. And we now have in-country confirmatory capacity at the NRL, the National Reference Lab in Abuja, NCDC's National Reference Lab. And I personally think that this should be the target in every country, and WHO should support every country right now in developing molecular capacity in their own countries to confirm yellow fever. And this will really strengthen the public health response across board, because it will shorten the time, give a sense of ownership to the countries, and really, really give energy to the yellow fever response the way it is given us in Nigeria. We have broadened our yellow fever laboratory network, the serology labs, from 4 to 6, covering every geopolitical zone in Nigeria. I mean, 6 labs covering a population of 200 million is still very low. So we really intend to do more. but we're starting with this 6 and then developing it into a hub and spoke network of labs for yellow fever and measles, connecting the national reference lab to the peripheral labs that are then ultimately pushing the surveillance for yellow fever in Nigeria. A few years ago, we held the largest yellow fever simulation exercise, I think, that's held anywhere in the world, in collaboration with our neighbors, the Benin Republic, to learn lessons across both countries in terms of response architecture, both from the triggering of a response, the activation of an EOC, and everything around a response to a yellow fever outbreak. We now have a completely digital surveillance infrastructure. So when a case is reported at the local government level, it's put into our digital surveillance system, SORMAS, which activates various players that have a responsibility around the response. And everybody's on the same page in terms of what needs to be done from the local, state to the national level. I think the most important thing, or one of the most important things, is really the development of local guidelines. Yes, we adapt and we are aligned very much to the WHO guidelines, but to have the specificity of actions required in the Nigerian context, we developed national guidelines on yellow fever at NCDC, which are then distributed to the states, available online on our website whenever you want. So when a healthcare worker does detect a case that might look like yellow fever, he can access these guidelines online. It describes exactly what needs to be done, what samples need to be taken, where they need to be taken to, what actions need to be triggered. And therefore, over time, people become used to what they need to do and are really empowered to do this themselves in the various contexts. And of course, we've continued to mobilize for more yellow fever preventive and reactive campaigns, understanding the limitations in timing. We've not had them as frequently, as rapidly as we would have loved to. The COVID response has really hindered us in a few ways, but really we've kept on pushing on these campaigns because we understand the challenges of routine immunization in our context. So in line with the elimination strategy, in terms of timing to reduce the time to confirmation of suspected cases, this is really what has driven the development of this lab network in the country and using the revised algorithm that now includes molecular diagnosis as a form of yellow fever confirmation. Very, very important to us. And we're very excited when the NCDC's reference lab, after many years of pushing, finally got accreditation for yellow fever confirmation in Nigeria. And like I said earlier, I think this is a strategy that, given the scale of rollout, expansion of molecular diagnostic capacity across the continent, it will be an incredible missed opportunity if we don't use this opportunity also to build up our yellow fever diagnostic capacity. And since then, we've really reduced the confirmation period from 30 days, certain cases in previous outbreaks, to less than 48 hours. And we want to maintain that consistently over time and really build, because that is what then triggers a response and builds confidence in all of us to have a responsibility around response to make sure that this happens as rapidly as possible. We've continued doing our campaigns. We understand while we're pushing, and our sister agency in Nigeria, the National Primary Healthcare Development Agency, that leads on vaccination, really pushing hard to strengthen routine immunization in the country. But we do understand the challenges that Nigeria faces. And with yellow fever, where the bar is very high for all of us, we really want to push that to have, a high vaccine coverage in our country. And we understand that that is, in a way, only possible if we integrate campaigns into our efforts. And that's really at the heart of the strategy in Nigeria. We continue to do this both through reactive, through preventive primarily, and when necessary, reactive campaigns across the countries. And we're making a lot of progress in this. So just to conclude, what have been the lessons that we have learned? Having strong in-country capacity on testing is not only important for the confirmatory process itself, it serves as energy to to provide vibrancy to the entire response, both the strategic long-term response, but also the immediate short-term response. When you have to wait for weeks to get a result from a lab that is, 10 countries away from you, it takes away the energy, the ownership, and the responsibility around the response. And so we've been very bullish on this, and we really encourage all other countries in the network to do the same. Every country, there's no reason with what we know at the moment, with the capacity that we now have across the continent, for every country not to have confirmatory capacity for yellow fever. And I really encourage WHO to support this and support countries across the region to do this. Yellow fever and other VPTs, vaccine preventable diseases, will very much benefit from a coordinated engagement across all of them. So this idea that each vaccine preventable disease has a different program that manages surveillance, diagnosis, and all of that is really something we have to challenge. We have an integrated approach at NCDC, and we will be working to support, encourage an integrated support to come from WHO. Yes, we know that there's a strategy around yellow fever driven by yellow fever targets, but there's no reason why we can't integrate this into broader targets for similar diseases for which there's a similar architecture, similar labs, and similar surveillance infrastructure. We do need to do a little bit more research and development, basically, than we have done up to now. And development. We're using tools that are very old and not standardized. And, to get the energy around the response that is needed for the future, we have to push hard to push yellow fever much higher up the research agenda than it is at the moment. I've complained severally about the timelines between ICG applications and delivery of the vaccines. I think that's been improving over the past 5 years, has been our experience. I think we can shorten that timeline even further by gaining some efficiencies both in the development of the application, but also in the delivery of the vaccines. And finally, if countries really need to take ownership around this. This is really what has led to the progress that we've made in Nigeria. Prior to the strengthening of NCC, the yellow fever labs really were reliant almost 100% on WHO for equipment, for allowances, for maintenance. All of that has changed. We have taken full ownership of our structure. Yes, we still need support from partners. It's critical for the future, but that support should not be targeted towards the sustenance of routine and rudimentary activities. We should and can do those ourselves. We're now doing that ourselves in Nigeria, and really encourage all other countries to do the same. Take ownership, let the countries lead, let partners support us, but countries must lead in the prevention, detection, and response to yellow fever in every country. So thank you very much for your attention. I hope I've shared a few thoughts and perspectives of the work that we've done in Nigeria, and I look forward to sharing this in different forums with you, but also learning from many people attending this session on your experiences and how together we can work to really control the transmission of yellow fever in our context. So thank you very much for listening.
Thank you, Dr. Chikwe. Now, he seemed so alive and with us, but that was actually video. So for the discussion session, we won't have him with us, but we will have him joining WHO in a week's time. Basically, his start date is the 1st of November. And a lot of the challenges, he kind of threw down the gauntlet on through some topics, but he actually will be responsible to pick up that gauntlet from the WHO side and see what can be done. His new role is as Assistant Director General for Pandemic and Epidemic Intelligence, essentially leading the global strategy for surveillance across all diseases. But we know he'll have a soft spot in his heart for what can be done on yellow fever, and really solid experience and recommendations to bring to the WHO level and help other countries benefit from that Nigeria experience. We have one more presentation before we go to the discussion, and several people, myself included, are having trouble uploading the app. So what we suggest you do is use good old-fashioned Zoom. We have that with us. If you look at the bottom of the screen, there's actually a Q&A question and answer function that you could use. Or when we get to the discussion session, you can just unmute yourself and ask your question, because I don't expect that we'll have too many to handle. So one last presenter before we go to that discussion session, we have with us Dr. Tahirou Diallo, who is a health worker in Guinea and will share his perspective on working on an outbreak of yellow fever, which happened due to immunity gaps in vaccination in children. So over to Dr. Diallo in Guinea.
Bonjour, je suis le docteur Diallo Tahirou, responsable de la surveillance épidémiologique au niveau de la préfecture de Koundara, à la dépêche de Koundara. Je commence par présenter la préfecture. La préfecture est l'une des 33 préfectures de la Guinée, située au nord, extrême nord de la Guinée, et puisque Koundara fait limite au nord avec le Sénégal, à l'ouest par la République de Guinée-Bissau, et à l'est de la préfecture, nous avons la préfecture de Mali et au sud, la préfecture de Gaoual. La préfecture est étendue sur une superficie de 5500 km² pour une population de 159 603 personnes, soit une densité de 28 personnes au km². Koundara a connu récemment une épidémie de fièvre jaune. Et les problèmes et défis que nous avons rencontrés sont d'ordre immunitaire, justement, puisque Koundara est reconnu par le PEV central comme étant l'une des 12 préfectures de la Guinée qui a vraiment une couverture vaccinale faible, c'est-à-dire inférieure à 80%. Et cela s'est confirmé lors de l'investigation de l'épidémie. Une enquête rapide nous a permis de voir que la couverture au niveau surtout des personnes âgées était de 16%. Donc à côté de cela, Koundara est à côté d'un parc, très grand parc sénégalo-guinéen qui s'appelle Niokolo Badiar. Le parc guinéen, c'est Badiar, c'est un prolongement du parc sénégalais. Et il y a toutes sortes d'animaux qui y vivent. Donc ces deux facteurs, plus le changement climatique, nous prouvent à suffisance que les épidémies pourraient éclater comme la fièvre jaune. Est-ce que c'est quelque chose qui était prévu? Oui. En bonne analyse, si vous avez une couverture vaccinale inférieure à 80% pendant de longues années et vous avez un parc à côté, notamment où il y a beaucoup d'animaux, les singes et autres, et avec ce changement climatique que nous observons dans le monde entier, c'est vraiment, il faut s'attendre à des épidémies comme la fièvre jaune, puisque tous les ingrédients sont là. Et comment faire des choses différemment pour que cela ne se reproduise plus? Qu'il faut, puisque et cela est prouvé, que nous avons pas seulement la fièvre jaune, mais lors de prélèvements, la plupart des personnes qui étaient positives à IgM pour la fièvre jaune, arrivés à l'Institut Pasteur de Dakar, ces échantillons ont été analysés et on a trouvé d'autres virus que la fièvre jaune, notamment le Zika et la dengue. Donc cela prouve à suffisance qu'il y a une grande circulation de virus au niveau de la préfecture. Donc pour vraiment faire les choses différemment, il faut procéder à la vaccination de tout le monde, surtout à l'anti-amarine qui s'est déclarée. Si j'avais une baguette magique, vraiment c'était de vacciner toutes les personnes de 9 mois à X années. Cela pourrait me rassurer que la fièvre jaune n'allait pas revenir à Koundara. Et maintenant, les domaines dans lesquels nous souhaitons vraiment l'appui des partenaires, c'est surtout au niveau du renforcement de la vaccination, en donnant la logistique, c'est-à-dire les chaînes de froid qui sont vraiment en panne dans les 7 centres de santé. Nous avons 4 centres de santé qui n'ont pas de chaîne de froid fonctionnelle. Mais toutes les motos datent de 2015, c'est-à-dire c'est des motos vieillissantes. Les stratégies avancées ne sont pas menées très bien et tout cela concourt à vraiment diminuer la couverture vaccinale et cela nous expose aux épidémies. Donc les partenaires, si ils pouvaient nous aider à avoir la logistique, avoir les chaînes de froid, avoir suffisamment de vaccins pour ne pas qu'il y ait de rupture avoir vraiment un approvisionnement régulier, puisque je vous signale que Koundara est à 617 km de Conakry. Et s'il faut aller à Conakry, il faut toute une journée ou parfois même 2 jours pour prendre les vaccins, pour les amener ici avec les moyens de bord. On n'a pas un véhicule d'approvisionnement et l'approvisionnement se fait à partir du PEV central. Donc, il se peut qu'il y ait des temps où on n'a pas du tout de vaccin. Donc, les ruptures sont fréquentes. Et maintenant, les conseils que nous donnerons, c'est surtout des conseils en direction de la République du Sénégal et de Guinée-Bissau. Surtout, c'est de renforcer la surveillance épidémiologique et notamment la surveillance à base communautaire, puisque ces maladies, c'est des maladies réémergentes qui ne sont pas bien connues par les populations, qui risquent de les confondre à d'autres maladies. C'est pourquoi j'ai donné cet exemple. Une fille de 14 ans, en pleine épidémie ici, elle a fait une fièvre, un ictère, et après elle a saigné, surtout par la voie basse. Au lieu d'amener la fille à l'hôpital, les parents ont pensé, la population a pensé que c'était un avortement. Et cette fille est morte, et certainement c'était un cas de fièvre jaune qui est décédé. Donc c'est des maladies qui ne sont pas connues et qui peuvent être confondues à d'autres par les populations. C'est pourquoi former les agents communautaires, les renforcer et les motiver pourrait nous aider à faire une bonne surveillance épidémiologique, et c'est à ce prix seulement qu'on pourra détecter rapidement les cas et les notifier et appeler vraiment l'aide pour que l'épidémie soit circonscrite dans un temps vraiment record. Je vous remercie.
Many thanks to Dr. Diallo for sharing his experience in Guinea with really concrete asks for partners and very concrete examples of their experience. And it's a shame. I'm so sorry we had audio problems during some of his presentation, because it was really stellar and incredibly interesting. So now we've arrived at the time to hear from you, especially if you've been able to get in touch somehow. If you've been lucky enough to download the app, we're looking at questions there. I don't think we have any yet, actually. And otherwise, you could drop your questions in the Q&A function in Zoom, or in fact, just unmute yourself and ask your question. So we should have with us still Dr. Ibrahima Sosefal. And we also have 2 colleagues I mentioned briefly earlier, technical colleagues from the I Secretariat. We have Jennifer Horton and Gumme Zhang. So please do ask your questions if you have any, and put up your hand. Let me see if I can see anything at the moment, or just unmute yourself and go ahead and ask, so that we don't miss if you do have a question. I might start off, Sose, sort of putting you on the spot with what Dr. Chikwe had said, specifically that WHO needs to support countries. In particular, he mentioned the PCR, that we should accept PCR as a confirmatory testing. Can you tell us, if you have the details, otherwise our technical colleagues may have, in greater detail, what the latest development is on that from WHO's point of view? Dr. Fall?
Thank you, Nika. And I think Dr. Chikwe has raised a very important point in terms of laboratory capacity. And you might recall that when we started the I strategy, we only had 1 reference laboratory for yellow fever, which was Institut Pasteur Dakar. Now I think we have at least 4 to 5 reference laboratories. And for Nigeria, we agreed at that time that Nigeria should be considered like a continent. They need to have the capacity to confirm yellow fever everywhere in their country. And this is the way to go. And we need to have now more countries performing yellow fever reconfirmation. It's not only about the PCR, because for yellow fever, you need to be able to do the seroneutralization to avoid confusion with other diagnostic. And so if we are able in countries like DRC right now to perform Ebola confirmation, even in remote area, compared to like 2 years ago, we need to aim the same for yellow fever. I think we should be in a position for all at-risk countries to be able to confirm the laboratory diagnosis, because we cannot continue to, to work like in the last centuries. We need to make sure that we have the rapid diagnosis, rapid confirmation, and strong surveillance system. It's part of the overall surveillance system we are talking about as part of the international health regulation. We cannot continue to send samples outside countries. I think this will be the next aim of the next phase of the health strategy. Thank you.
Thank you, Dr. Fall. We have Dr. Tomori who has their hand up. Please go ahead, unmute yourself and ask your question. Professor Tomori. I don't know if we have to unmute as well.
Hello, can you hear me?
Yes, we can hear you. Please go ahead.
Thank you very much. Today is a very good day, and thank you for the comments that have been made. I just wanted to make one comment about the fact that what Chikwe and others are suggesting has been something that has been WHO policy for a long time. It's just that we refuse to sustain what we have agreed upon. The issue of integrated disease surveillance started way back in 1997. And the polio network was responsible for that. Out of that grew the measles network, the yellow fever network, and all those other networks. But I think the problem is sustained is the problem of the country. And many of the times WHO starts with this, and then the countries don't sustain it. And then we go back to square one, which is what is happening to us, or what is currently happening to us. Many of these countries had the WHO recognized centers, diagnosis centers, which were running all these things in times past. But then the countries neglected these ones, and then we're back to the square one where we are. I think the message is not just to WHO, it is to the countries that when WHO establishes whatever it establishes, countries should be there to sustain what has been established. We cannot going back and forth to WHO to do this, do that, when the countries themselves are not sustaining what they have. I think this is back to the countries. Now, once something is established, please try and sustain it. And that's what is killing us right now. Over.
I guess in that case, we have the responsibility to look at, did you say over, Professor? I think so. I think what you're raising there as well is that if countries aren't able to sustain, we need to understand what it is and where they need the support. And that's why Professor Diallo, Dr. Diallo's presentation was so interesting, because he was very detailed on what exactly was needed there as well. Do we have any other questions?
I think Nika Sosa, I think the point raised by Professor Tomori is so important in terms of country ownership and real commitment. Because this is a matter of health security in general. You cannot expect the security of your population to be, driven by external partners. We need real national commitment, materialized by domestic financing to be able to put some of the minimum capacity we need for the most prevalent diseases in our country. I think this is really, we stimulate, we provide technical guidance, we mobilize partners, but definitely we need strong country ownership and political commitment to be able to protect their own population. Thank you.
I guess I would say it also comes back to us, in a sense, a kind of advocacy to help countries understand why this is a good investment. And I think COVID helps with that as well, doesn't it? Showing that increase in diagnostic capacity can help you, that's needed overall. And it's something that Professor Chikwe, Dr. Chikwe was also highlighting, how incredibly important it was to have the local capacity, not just because of the speed of diagnosis, but because of the ownership that it gives people in the response, knowing that you can do the confirmatory testing yourself. We sometimes see that in Ebola outbreaks, the difference between a country that can confirm for themselves and one that has to send the samples away and wait some time for confirmation. I don't see, let me see if we have anything else. All right. I will read this comment from Alison Jane Basile. She sent it to everybody in the chat. She writes to Dr. Fall's question, a PCR kit has been approved for the yellow fever network. Reagents are being procured to support the use of the kit, and training is planned for the next few months. This will allow yellow fever confirmation in many labs for early samples. The performance of PRNT in multiple laboratories is not as feasible for confirmation using serology. I'll just ask Dr. Fall if you have anything else to add. Otherwise, we'll move on to our next session.
Thank you, Nika. I think you can move to the next session.
All right, with your blessings, that is what we shall do now. Colleagues, Laurence is also listening in, but as I said earlier, has the connectivity problem, so it's not possible for her to join, but she's listening to all of your input as well. So the next session, session 3, is Global Efforts Enriching the Eye Strategy, and we will have 3 presenters on this one. We'll start with Dr. Jose Castilla, who's a senior emergency officer, a colleague of mine here in the emergencies program. Dr. Kate O'Brien, Director of Immunization, Vaccines, and Biologicals at WHO, another colleague. And lastly, a third colleague, Dr. Raman Velayudhan, who's Unit Head, Veterinary Public Health in the Vector Control and Environment Unit of the Department of Control of Neglected Tropical Diseases. So we're going to start with you, Dr. Castilla. And one of the things we really want to get out of your presentation is to understand bundled service delivery and how it can improve health, especially in those fragile, conflict-affected, and vulnerable settings. Over to you, Dr. Castilla.
Thank you very much, Nika, and thank you to Professor Olewale, because his question just gives the perfect context for the presentation I will do. No slides though. So let me use less than a minute to tell you a bit about WHO structure and plan. And in WHO structure and plan, there is a first goal to help the vulnerable, which in practice translates by health services and systems and the expansion of universal health care. Another goal of improving health, which is everything that is a determinant of health, like nutrition, water, and so on. And the third big division and goal is to prevent, prepare, and respond to emergencies. And in the response part, the division is led by Dr. Joseph Fall, who you heard before, and has departments that respond to acute events such as a hurricane, for example, or to protracted crisis, which in fact are 85% of the people affected by emergencies. So this division on emergencies in protracted crisis in particular would lead me to an old African saying that I love, because it's so true, that says, if you want to go fast, go alone, and if you want to go far, go together. So Dr. Olewale is talking about how can we ensure the sustainability. If you go fast and you do everything in a very autonomous way, you will go fast and you will cover people to control immunity. But if the yellow fever actions are bundled together with other high impact and priority health interventions, we are going to use a common set of support, such as logistics, human resources, and so on and so forth. So in fact, a bundled package of services is accessible.
1 second.
Yeah.
1 second. A few people are saying they're having trouble hearing you. And before you get into this very important definition, I wanted to just pause. Your sound is clear to me, Dr. Castilla, so I'm not sure what it is exactly. There is a note saying that if you are listening to translation and you're listening in English, the note is turn off translation if you're listening to English. That should help with the sound. I don't know if that works. So i.e. don't listen to English on interpretation, just click on off. And that's the setting I'm on, and I can hear him quite well. So that's what I suggest you do. Go to the interpretation icon and choose off if you're listening in English. I don't know if there's a similar problem in other languages. Back to you, Jorge. Hopefully a few more people are able to hear you. And again, I apologize that we've had so many audio problems.
So thank you. I hope you hear better, and I will be more than happy to do it in French. So it will take more time if we do both of them. Now, for the fragile and conflict settings that are in fact those that host 85% of the people affected by emergencies, have a very long duration. The mean duration today is 17 years. So indeed, the sustainability is a very important aspect. And therefore, we have been working on, in those settings, it's not easy to provide the full service package that the country designs, because there are difficulties such as areas that are very difficult to access. So we have been working on something that we call 3H, or a high priority health interventions in humanitarian settings, which tackles vulnerable populations in those fragile and conflict settings, and uses the same pipeline of commodities, the same human resources, the same pillars of the health systems to be able to go far together and have an intervention that is prolongs on the time. Now, it allows also an efficiency of resources and better sustainability. Each program by itself is quite expensive because they will develop their own paths to deliver by bringing together a number of high priority interventions. There is the possibility to have common elements, and it allows us, of course, to collaborate with others. Now, the fragile and conflict affecting settings are important because these are many people. The people living in those settings today are 250 million, including, for example, refugee camps, and they are in countries that themselves host 1.8 billion people, but they account for more than half of the maternal and child mortality. Now, Kate O'Brien is going to talk just after me, and she's going to talk about the Immunization Agenda 2030. And it's important to know that in this immunization agenda, there have been special work streams for the control of epidemics, in particular innovative approaches for conflict and fragile settings. And therefore, this is all part of the overall immunization agenda. And I would like to end this short intervention by talking about how COVID has affected the way we work, and I will do it in two ways. The many things that COVID control can learn about yellow fever that has been working in areas that are not so easy to reach, but also in using the example that Jane put on the chat, how the distribution of PCR capacities for COVID is also something that we can use today in order to have a better opportunity of a strengthening rapid detection of yellow fever. So let me leave it like there, and more than happy to address more deeply on the question and answer sections. Over.
Thank you, Dr. Castilla. As you said, you will stay with us and you can join us for the question and answer session as well. Next, we have our colleague, Dr. Kate O'Brien. She'll be speaking about the Immunization Agenda 2030, which is another of the broad strategies that the iStrategy aligns with. The arbovirus one is another one. The goal of that strategy is protecting almost 1 billion people. By 2026. Dr. Kate O'Brien is the Director of Immunization, Vaccines, and Biologicals here at the World Health Organization. You've probably seen her speaking a lot about COVID recently. And she'll talk about the vision and goals for the next iteration of the Immunization Agenda 2030. Over to you, Dr. O'Brien.
Thank you so much, Nika. So I have just about 10 minutes to really weave in to this fantastic annual meeting of the iStrategy partners about how I and Immunization Agenda 2030, along with other disease-specific strategies, are knitting themselves together to get more impact out of similar investments. So I'll go to the next slide, please. And this is a global strategy to leave nobody behind. It's an ambitious global strategy for the decade with the intent to maximize, and I really want to emphasize that, to maximize, that means optimize the life-saving impact of vaccines in this decade. And the goals have been established with targets. So by the end of the decade, IA 2030 aims to reduce by 50% the number of children receiving none of their vaccine doses through the immunization, the routine immunization program, so the so-called zero-dose children. It aims also to achieve 500 introductions of new or underused vaccines in low and middle income countries. And thirdly, it aims to achieve 90% coverage for essential childhood vaccinations. There are other targets embedded within IA 2030, but these are the primary top level ones. Next slide, please. Now, the IA 2030 strategic framework lays out a set of 7 strategic priorities that are informed by 4 core principles, all of this directed towards the impact goals and targets that I've just laid out. And these, I just want to remind people that these, the whole of IA 2030 was a co-creation process. It was a co-development process over a period of about a year to a year and a half that involved deep participation and generation of ideas about what was actually happening in the course of the decade of vaccines, the Global Action Plan for Vaccination, and what were the things that needed to be course corrected. And so the 7 strategic priorities, the overarching one, which is shown in the orange umbrella part or rainbow part, if I can put it that way, is that immunization programs are for primary health care and universal health coverage. That's the overarching strategic priority. And then the remaining 6 really speak to the importance of commitment and demand to achieve coverage and equity, embedding a life course approach and integration of vaccines into a variety of primary health care approaches and universal health coverage, with the intent to limit the size of outbreaks and address emergency situations. And this, of course, is grounded on having adequate supply that is based in healthy markets and is sustainable for countries. And clearly, almost every element of these strategic priorities are underpinned by research and by innovation. And every part of the Immunization Agenda 2030 and the strategic priorities has to be actioned through a set of core principles, which are that everything that we do should be people-centered, so very much a human-centered design approach, should be fully owned by countries, based in partnerships, and guided by really high-quality data. So I'll go to the next slide. As we take that sort of conceptual vision and really live out each of those things, we expect that there will be new achievements in this decade. And what's new in IA 2030? How is this, what I just laid out, different from what GVAP was about or before that, other global vaccine strategies? And so the model for the global level partnership has changed completely for IA 2030 compared with the last decade. The integration of vaccination into UHC and PHC, putting that really at the center, is a new development. The fact that this was co-developed and co-designed by countries, by regions, and by global partners without first coming to countries with an idea, we essentially created the process wherein countries could be at the heart of designing this. The tailored monitoring and evaluation framework is adapted to country context. There are not a large number of quantitative goals that every country has to meet, where we found that some of those countries had already met, and so there was no target for them, or some of them were clearly unachievable by some countries, and so as a result, we're not motivating influencers. It addresses immunization coverage and equity at the heart of IA 2030. It really focuses on stronger systems and addresses gender-related barriers as part of those stronger systems. It also puts broader and stronger partnerships, both in immunization and in health and beyond, as a means by which to achieve the goals. And it integrates the disease-specific initiatives, which we'll get into a little bit more since the I initiative is one of those, and ensures a self-sustainable set of programs. So these are the ways in which IA 2030 is disruptive of and distinct from the decade that we've just completed on immunization efforts. Next slide, please. So I do want to acknowledge that at the early October SAGE meeting, we went through a set of the quantitative measures of the backsliding in immunization at the start of IA 2030. Unfortunately, we're starting IA 2030, I would say, in a hole. The global coverage for DTP3 went down for the first time in a decade, down by 3%, mainly due to the pandemic and to COVID-19 vaccine rollout, which was just initiating. From an equity perspective, the coverage in the 20% of the worst performing districts fell for DTP3, MCV1, and MCV2. And these falls were greater than those that were seen for the global coverage, which really indicates that poor performing districts fell further and harder in 2020 than better performing districts, further increasing the inequities in vaccine coverage. The number of zero-dose children increased by 3.5 million, largely experienced in Gavi-eligible countries. And with respect to introductions, only 22 vaccine introductions into national programs took place in low and middle income countries. This is the lowest in over 10 years. And as a result, the risks of outbreaks increased. There are an increased number of CVDPV outbreaks in 2019 and 2020, but a sharp drop in the measles outbreaks in 2020. This year of lockdown has taught us many things about respiratory diseases, not the least of which is respiratory diseases are infectious, and when you interrupt the behaviors that lead to transmission, diseases do go down. Now, there is a further risk of backsliding in 2021 as a result of both the pandemic and the enormous strain being put on immunization programs and essential health services writ large as a result of the intense effort to roll out COVID-19 vaccines and end this pandemic. So I don't think we're out of the woods yet in terms of the backsliding. Next slide, please. So in terms of IA 2030, we have a scorecard of indicators and targets with a baseline year and then a measurement in 2020 as the first year of IA 2030 period. And some of these indicators are specifically related to yellow fever contributions. So the first one is the number of future deaths averted through immunization. The modeling has led us to a target of 50 million future deaths averted in 2021 through 2023, if the targets for vaccination are met. And yellow fever certainly contributes to this. On indicator 1.3, which is the number of large or disruptive vaccine preventable disease outbreaks, the target is to have a declining trend in the annual number of these outbreaks, with a baseline year established with 4 yellow fever outbreaks, and already in 2020, a measurement of 5 such outbreaks. So certainly not going in the right direction at this point. Next slide, please. We have other indicators on the number of zero-dose children, the introduction of new or underused vaccines in low and middle income countries, and clearly there are still countries that have not yet introduced yellow fever into the routine immunization program, so 3 countries. Vaccination across the life course, again, from a campaign perspective, yellow fever fits in here. Here we're talking about routine immunizations, and then the UHC index of service coverage. So each of these are these critical indicators to measure through a scorecard approach the progress on IA 2030. Next slide, please. The vision of IA 2030 is a world where everyone everywhere at every age fully benefits from vaccines for good health and well-being. And if we see how the I strategy aligns together with IA 2030 and where the strategic priorities of IA 2030 and those of the I strategy line up, we see a really a very nice and very strong alignment. So the I strategy is a world without yellow fever epidemics. Obviously, the contribution of IA 2030 to that vision of that world. And the IA 2030, the I partnership aims to protect at-risk populations, targeting 40 countries, prevent international spread, and control outbreaks rapidly. Again, each of these linking very carefully and very clearly with strategic priorities in IA 2030. And there are a set of competencies for success: governance, political commitment, improved vaccine supply, synergies with other programs and sectors, and research and development. Again, each of these is embedded in the IA 2030 framework. Next slide, please. So in IA 2030, one of the means by which it's being actioned is through a set of working groups. And you can see the list of multi-partner working groups, the focus areas for these working groups for IA 2030, and who the lead partner is. I want to emphasize that IA 2030 is everybody's strategy for the decade for vaccination. It's not WHO's strategy or UNICEF's strategy. We don't own this strategy alone. It's the contribution of everybody. So you see the lead partner for each of the strategic priority working groups, and those that are colored in yellow are the ones that have a significant representation from the I approach. So half of the IA 2030 working groups have that representation from I. So there's a really important opportunity, and we have to seize the opportunity for broad engagement on these cross-cutting issues. There's also a set of indirect connections with other working groups that ensure yellow fever prevention and control are viewed as priorities along with the other vaccine preventable diseases. Now, in particular, you'll see this disease-specific initiatives working group. And this is a working group that brings together representatives from the eye strategy, cholera control, the polio program, measles and rubella, defeating bacterial meningitis by 2030, and the cervical cancer elimination project, as well as the maternal and neonatal tetanus elimination. And this is an area where we really think it's important for each of these disease-specific focus areas to sit together, because there's not a single one of these that doesn't have surveillance, immunization, data strengthening, cross-cutting issues on routine immunization. They're all talking about the same things, but each within their own specific disease specific initiative. So I think this is going to be one of the most dynamic of the working groups to actually have people seated together to drive at these issues in a more aligned way. Next slide, please. And I'll stop there and leave for any questions or comments. Thank you.
Thank you, Dr. O'Brien. If you can just stay on the line with us for as questions come in, and we'll have just one more speaker as well. I want to mention that Dr. O'Brien is another one of the people we've had on the I podcast. So we'll drop the link to that in the chat as well. So if you like these presentations today, then you will surely love the podcast. Not only do you hear these excellent people and all their ideas, it's a slightly different setting because it's an interview format, so it's more relaxed in a way. And there's beautiful sound design woven in as well. So please do have a listen to the I podcast. And I'm not just saying that because I host some of the episodes. So please do drop your questions in Zoom at the moment. We're monitoring all platforms. So if you're using the app, please go ahead and drop it there, but we haven't had a lot of questions actually. If you're using Zoom, there's a Q&A icon that's right beside the interpretation one if your layout's the same as my screen. So at the bottom of the screen, right-hand side, you have interpretation, and then next in you have the Q&A function. So you click there and can drop a question. There's a question on fractional dosing there in there at the moment. Next, we have Dr. Raman Velayudhan, who is also one of the people we spoke to on the I podcast. He's the unit head, veterinary public health, vector control, and he's the unit head for veterinary public health, vector control, and environment. And he's that's in the Department of Control of Neglected Tropical Diseases at WHO. He's been instrumental in the development of the forthcoming global arbovirus strategy, which is one that brings together all the diseases that are caused, or the main diseases that are caused by the Aedes aegypti mosquito. And he will speak to us next. Dr. Velayudhan, over to you.
Thank you very much, Nika. Let my slide come over. So basically, before I begin, I really want to thank the Secretariat for this opportunity, and also to tell all the participants here that this is a draft. We have not finalized this, and there is a chain of emails going around from our Secretariat to many people to participate in our stakeholder consultation. And as you can see, this is a big program with cross-cutting across WHO. Several departments are involved. We started with 3, but we may end up with more. And we really like the way we are working across with all our expertise being channeled for a particular cause. Next slide, please. So basically, the global arbovirus is focusing in its initial stage on Aedes-borne diseases. And this is mainly because we must not forget what happened in 2016 when we declared Zika as a public health emergency. And Zika was really a frightening situation. It had spread across many countries. And you would be surprised to know that it still lingers on. We still, even today, we had a report from India of a Zika case being recorded. So it's under investigation at the moment. So this map really shows one of the biggest challenge we face. We are talking about Aedes mosquitoes. And this mosquito has expanded to over 150 countries. Today, dengue alone affects 129 countries. And Lancet had described it as the only communicable disease which has expanded 6-fold since 2000. So we really need to address this problem. And it is a vector which is a big problem, which causes most of these problems. So this map clearly highlights 3 diseases: dengue, chikungunya, and Zika. The darker the map, the more diseases you have. And so you can see how these diseases are affecting not only the tropical belt, but it is even affecting countries like Australia, parts of the US, and surprisingly, many countries of Europe. Next one, please. So here, just to give you an idea, we are in the midst of a pandemic. The whole global attention is on it, rightly so. But here we are. Today, we have more than 1.2 million dengue cases confirmed from over 40 countries. There is emergence of Zika in many pockets. There is in Chad an outbreak of chikungunya. And as I said, these diseases are occurring along with COVID, and especially in Southeast Asia, dengue and COVID is causing a lot of confusion. So there is a growing discussion among the doctors that WHO should come up with a guideline to manage both, especially at the hospital level. So this is the scenario today we have. Next slide, please. So what are we talking about? We are really talking about these 2 beautiful mosquitoes. They are causing havoc. We have 4 diseases: dengue, chikungunya, Zika, and yellow fever. Transmitted by them, Aedes aegypti is the primary one. Albopictus is fast picking up. Albopictus is more common in Europe. It knows to hibernate, and today has established in 22 countries of Europe. So it just shows you that these mosquitoes are in your background. Next one, please. So what we really came up in 2017 after the Zika crisis was that we developed a global vector control response. And we really want to build on this, where we want to strengthen basically the surveillance component, engage with communities, strengthen intersectoral cooperation, and scale up the intervention. Now, all these are nothing new. We all do that in most of these diseases. And I really wanted to remind this on because many countries are focusing on improving some elements of it. Next one. Yeah, so basically this arbovirus strategy, what we are doing right now is to bring all these many developments together. We want it as an overarching strategy, which is integrated to detect, prevent, and respond and control to Aedes-borne diseases. There are innovative tools in the pipeline, including vaccines, vector control tools, even medicines are being developed. There is improved clinical care in all these diseases, so we really need to capitalize on that expertise. We need to empower communities ultimately. So this is the, can I go back, please? Sorry. So this is the main area where we want to support surveillance, prevention, and sustain the vector control part. And we also want to raise the global alarm, because one issue which is at the back of most of us is that we are sitting on a hot spot, and that is the whole area of Africa where many arboviruses are still there, but we are not fully recording them. You have just given us a very good presentation on yellow fever, but there is dengue lingering there. There is chikungunya. There may be Zika, and there may be others. So we really need to sensitize all the sectors and make sure that we work together in order to address this growing problem. And this is also a problem. The vector, why we are emphasizing on vector is they are going to be the main players in an urban environment. These vectors are experts to capitalize on an urban environment and establish themselves. Even countries like Singapore are struggling to control this mosquito. So we really don't want to be taken aback. We really need to go up front and confront this vector, which is causing havoc in our lives. Next one. So the global arbovirus strategy is basically, we have developed it as several pillars. We are, as I said in the beginning, this is a draft. We are going to solicit comments from many of you. Those of you who are interested to help us in this endeavor, please contact the ICE Secretariat. We will be happy to include you. And so we basically are looking at several pillars, each of which we will go through one by one. Next one, please. So the first one is basically monitoring risk and anticipation, basically to develop a global risk monitoring framework. Forecasting wherever possible. We have some in-house tools which we want to scale up, especially for covering all arboviruses. Next one. The next one is to reduce the risk of epidemics. So strengthen early detection, improve capacity, improve response to arbovirus outbreak, and increase population protection through yellow fever vaccination and high-risk areas where we can harmonize, because yellow fever gives us another window to mainly detect and do the risk assessment and monitoring part of these vectors. And as the previous speakers have said, the threat of urban yellow fever outbreak fits in very well with this arbovirus strategy, because this is also focused on urban areas. We want urban surveillance to be significantly scaled up, especially on the entomology side and the vector control part. Next one, please. So the vector part is, as I have emphasized, is the surveillance, strengthen vector control, and preparedness, mainly in urban and densely populated areas, where if any of these arbovirus affects, then it will really be a big outbreak and we want to avoid it. Next one. The fourth element is basically to prevent and prepare for pandemics, enhance global coordination, strengthen global surveillance mechanism for rapid response, strengthen community engagement and resilience, and develop and strengthen countermeasures. The last one, please. So the fifth one is, of course, to build partners like all of you. We are most welcome to join this endeavor, strengthen partnership, and enhance communication among stakeholders. Next one. And so the last element is to develop an integrated public health research agenda for our Aedes-borne diseases, support development of innovative tools. We want to integrate these innovative tools as and when it is available. There are several new tools in the pipeline, and we want to develop new tools and approaches for public health preparedness. Next one, please. So basically, we have been working on this since 2019. The pandemic slowed us a bit, but in the meantime, there is also an NTD roadmap which covers dengue and chikungunya. We are establishing a technical advisory group on our arboviruses, and we hope to convene the first meeting of that. As I said, several key stakeholder meetings are planned in November, and we hope many of you can participate in it, and we hope to finalize this document towards the end of the year. Next one. So this is the timeline, and what we really have is we have some, thanks to US CDC, we have some funds to start working on 3 of the pillars: monitoring risk, reducing epidemic potential, preventing and preparing for epidemics. So those parts, we have some funds to work on, and we will be working very closely with the regional office and countries in moving this document forward. So as far as yellow fever is concerned, as I said, detection, risk monitoring, and preparedness is a key, and added to that, the vector surveillance component in urban setting would be very useful to make sure that we do not lose track of any of these arboviruses, and we can bring immediate control in case there is any potential outbreak, which we hope we can avoid. So I'll stop here. Thank you very much.
Thank you, Dr. Velayudhan. So we now have our 3 panelists online with us still. So that was Dr. Jorge Castilla, Dr. Kate O'Brien, and Dr. Raman Velayudhan. we don't have questions for all of them, but our colleagues within our smaller chat have posted a few. But we do have one question here, which I don't want to skip because we've been asking you for questions, and when we do receive them, we should ask them. So this is for you, Dr. Velayudhan. It's from John Olson, and you'll see he doesn't mince words. He is saying, surely all our worldwide efforts should be to kill the mosquito larvae in the water before they become deadly, flying, blood-sucking syringes. So put another way, shouldn't we do the vector control when the bugs are at the larva stage rather than waiting till they're flying around?
Well, it's definitely one of the options. To be honest, Aedes mosquitoes cannot be easily controlled. There are several reasons for it. One, they breed in all sorts of containers, so you cannot detect them. They may be on your roof, they may be in your gutters, they will be in small coconut shells. So it's practically difficult to detect them. The second challenge, which only Aedes has, is that its eggs can remain dry for 1 year or even more and hatch as soon as it comes in contact with water. So you really don't know where they will hatch next. So this is the challenge we have with larval control. So for Aedes, we need both larval. We are trying to target the most productive containers and then also the adult control. Thank you.
Thank you, Dr. Velayudhan. We have a question here. I can't see it though, but I understand there's a question from Professor Tomori. Would you like to go ahead and unmute yourself and ask your question directly?
Yeah, thank you very much. Just to again commend this new initiative, which I just wanted to say that at one time, WHO had WHO arbovirus or arbovirus research and something centers in different parts of the world. Then PCR came and we abandoned and forgot that mosquitoes are out there biting us, not inside the PCR lab or something of that nature. And I quite support what Rama said about the issue of mosquitoes. I do remember sometime in I think it was 94, so in Liberia during the war, that we found mosquitoes breeding in abandoned vehicles. The tank, the water that takes the tank for the wipers. Mosquitoes were breeding in such abandoned things, and we isolated yellow fever from such places. So the holistic approach is what we need. WHO used to do that. Then we all abandoned that. I'm glad you're coming back to it. I hope we sustain it this time. Thank you.
Thank you, Professor Tomori. I have a question for Dr. O'Brien. You said that the strategy you presented is an overall one and it's for all diseases, but at the same time, there are reasons to focus in on specific diseases, such as the colleagues on this call are focused in on yellow fever. What are the synergies? What are the way in which a global strategy can help an individual disease, and what are ways in which an individual those focused on an individual disease can help with overall vaccination goals? That's for Dr. O'Brien. You may need to unmute yourself. I can't hear. I don't know if other people can.
No, I can't hear Nika.
No.
Is Dr. O'Brien trying to answer?
Can we see if she's still in the panelists? Is she still with us? I'm just trying to have a look as well here at the top. Oh, she may have had to drop off. And yet that was such a good question.
I think she did have competing meetings today, Nika, but we can always take the question and put it to her and then get a response for whoever's asked the question.
Well, it was me, actually.
Oh, I see.
I'll ask for myself next time I see her.
Okay.
Next, for you, Dr. Castilla, could we start to see yellow fever prevention and control integrated into the fragile, conflict, and vulnerable response context? Or would it need to be more selective, driven seasonally, or in countries where we know there's a threat? Or is it something that you would fold in and have ready just in case?
So when there, in this context, there are a number of partners that are working together, and frequently they choose their specialty. For example, they do particularly children or non-communicable diseases. And by doing so, they really fraction the efforts instead of bringing it together. Yellow fever, in my opinion, I think we are in agreement now, is to be integrated in the overall vaccination strategy, and vaccination should be integrated with other of the main causes of mortality and disease as malaria, respiratory infection, and so on. People need to receive the key interventions, but also need to feel that their main personal perceptions are being satisfied. And therefore, this integration in a bundle of interventions, that being a bundle will in fact strengthen the health systems, which you will need in order to deliver after year 4, year 5, year 10, and so on and so forth. So the integration should be in every setting where yellow fever is considered a risk that requires regular vaccination on children. Of course, not in every setting in the world, but I think that we have a good handling of the disease profiles, and in fact, these countries that host these settings are around 75 to 80% of all the recurrent big outbreaks: yellow fever, cholera, meningitis, and a certain number of viral hemorrhagic fever. So it is kind of such a rational, cost benefits, and more sustainable approach. Don't hear you.
Thank you. We're actually exactly on time to take a break now. So I thank you, Dr. Veladjuhan. I thank you, Dr. Castilla, and I thank you, Dr. O'Brien, in your absence for your time with us today. So we're going to take a 9-minute break and be back at 1:15 the hour for our last session today. So thank you very much, colleagues, and we'll see you in 9 minutes. We're going to have I get that message on recording. We're going to have the discussions after each presentation. So again, please drop your questions in the chat, drop them in the Q&A function, actually, which works quite nicely, or in the app if you've managed to download that one. So everything all right? We'll go ahead and start. The first session, as I said, is going to be on Africa, and we have with us 2 colleagues from that region. We have Dr. Richard Mihigo, the Program Manager for Immunization and Vaccine Development, and Dr. Ambrose Talesuna, leading emergency preparedness in Afro as well. Please go ahead. Veuillez, s'il vous plaît, commencer votre présentation. Merci.
Thank you very much, Nika, and I will be presenting on behalf of Afro because Richard is struggling and it is one presentation. And my presentation is titled Progress in Implementing of the Elimination of Yellow Fever Epidemic Strategy in Afro. So to start off, really, the implementation framework for our region was adopted during the 67th session of the Regional Committee in September 2017. And there are 3 strategic objectives of the implementation framework. One is to protect at-risk populations, doing things like preventive mass vaccination campaigns, vaccine delivery for every child, risk prioritization and analysis. And then the second priority is preventing international spread. So vaccination of travelers, robust screening and on-site vaccination of people who are not vaccinated. And then the final one is really aligned, of course, with the global strategies: rapidly detect, confirm, and contain outbreaks, issues around strengthening surveillance and laboratory capacity, streamlining international sample transport, and ensuring that we have emergency stockpiles of vaccines and also immediate outbreak response. So we have our milestones. So we had by end of 2019 that all the countries have initiated the implementation of the framework. 3 laboratories in Africa will have functional capacity to confirm, and all at-risk countries will have introduced yellow fever vaccination into the routine immunization, and then preventive mass vaccination campaigns will have been completed in several countries, including Angola, Congo, Ghana, Nigeria, the DRC, and Uganda. And then by 2022, we'd really would have 6 sub-regional reference laboratories, which would be functional for both serology and molecular diagnosis of yellow fever. And 6 of the 13 high-risk countries will have completed preventive mass vaccination campaigns, and 3 new ones, including Guinea, Ethiopia, and South Sudan, will have initiated mass preventive campaigns. And finally, that at high-risk countries will have established diagnostic capacity to confirm yellow fever. So in terms of initiation of the framework, the original target was first of all to have the 13, and so 12 countries have already completed the eye implementation plans, and 4 out of 12 have completed plans. Their plans have been validated. 1 plan is yet to be completed, but it has been delayed because of COVID, and that is a Chad, and that's really the map that shows the plans that are either completed or validated. So this is the regional reference laboratory outlook. Before 2017, we really had only 1 regional reference laboratory, Institute Pasteur, which could confirm yellow fever. And I remember when I joined WHO in 2016, when we had a huge outbreak in Angola and the DRC. And I think most of the samples probably were being taken to Institute Pasteur in Dakar. The outlook now, additional 3 laboratories are able to do that in the Uganda Virus Research Institute, the Center Pasteur in Cameroon, and of course onto that. But really the target is really to move away from this and increase the number of laboratories. But the good thing is that at least some countries now are doing their own confirmation. And this is really, so sub-regional national laboratory capacities now, apart from the 3 reference laboratories already operational, we have, you heard this from Chiko's presentation, a regional laboratory, at least in Nigeria, in Abuja, so that's functional. So I think we can say, and has been accredited. Work is ongoing with the Yellow Fever Lab Network team for accreditation of 5 other laboratories in Cote d'Ivoire, the DRC, Burkina Faso, Kenya, and Ethiopia. And then most high-risk countries are actually currently able to perform molecular diagnostics in their national laboratories. And 2 diagnostic capacity building workshops have been held for countries, will be held before the end of 2021, planned, I think, before the end of 21, and work is in progress with the Yellow Fever Lab Network team to follow up the national laboratories which are accredited for the last 3 years. In terms of where we are with respect to vaccine, yellow fever vaccination, again, you can see the map showing new countries that have been introduced in green, and 24 of 27 at-risk countries have introduced yellow fever vaccine in their routine immunization program. 1 country, Kenya, has introduced only in high-risk areas in 3 counties, and Uganda and Sudan are in the process of introduction. Actually, the applications have been approved by Gavi, and we hope that this will be done very soon, early next year. Ethiopia and South Sudan are yet to introduce, but again, I have to say that the decision to introduce new vaccines is taken by the country according to their priorities. In terms of routine immunization coverage, these are data for 2020. You can see 9 of 20 countries have vaccination coverage above 60%. And 2 of 20 countries have vaccination coverage actually above 80%. But there are areas where you can see countries that are really below the target. So we really need to be doing some additional work to ensure that we turn around some of these numbers in terms of vaccination coverage. This is the map of Africa showing you preventive mass vaccination campaigns. 11 countries are yet to complete national campaigns, but we have some where we have ongoing work in the DRC and Nigeria. And then we have next steps, countries that we are really saying next steps where we need to do final quarter this year, Sudan, Congo, Uganda, maybe in 2022, Guinea-Bissau, Ethiopia, and Equatorial Guinea. The total of over 145 million people have really been protected via yellow fever mass vaccination campaign since the eye strategy started, and over 70 million additional are planned in the next couple of months. The timeline for anticipated application of implementation, this is really for preventive mass vaccination campaigns. You can see application based on the risk analysis 2021, Ethiopia, which has already done a risk analysis. And then we have a whole set of countries that are lined up for 2022 and 2023, and then the implementation as well. Look at, again, routine immunization, what I've been talking about, applications with Ethiopia and South Sudan in 2022, and hopefully Uganda to implement in 2022 as well. And another set of countries, if South Sudan and Ethiopia, if Ethiopia and South Sudan do their application, then we anticipate that they should be implementing in 2023. This is a map that you saw from the I presentation earlier from my colleagues in headquarters, which is really showing the distribution of cases reported and outbreak response conducted between 2020 and 2021. And you can see huge outbreaks, of course, some of them in Ethiopia. We have had an ongoing outbreak now in Nigeria, Guinea, Niger. But you can see the ones in red where ICG supported outbreak, and then others where potentially some of them we are still doing the risk analysis. But the critical bit, I think, is really for us to be quickly doing the risk analysis, and we'll be able to respond to these outbreaks as quickly as possible, because timeliness is of essence if we are really going to eliminate any of these epidemics. What are the challenges that we have faced? I think because of COVID, we have had a delay and an increase in costs for activity implementation. There are risks of increasing yellow fever vaccine hesitancy due to misinformation about vaccines in general, and we are really seeing a lot of vaccine misinformation during the COVID vaccine. We hope that this really will not spill over, so we really need to be improving our communication around that to turn this around. Decision-making of some countries for routine immunization introduction has been slow. There is also persistence of low immunization coverage leading to resurgence of epidemics in some countries. And also some countries really should be moving towards case-based surveillance, and we really, we should be able to ramp this up. The other is, of course, challenges in domestic sample transport affecting our efforts. But also the risk is that really we have human resources. We need to be monitoring our human resources. We are been using some of the surveillance people from the polio. Polio is now ramping down, and we need to rethink how we are going to support yellow fever surveillance and the kind of human resources we need to have there to do case-based surveillance, and also for every event that occurs. There is poor implementation of the international health regulations in most countries. We hope that this will change. I think COVID is a lesson for us to learn. Uncontrolled population movements, and then no yellow fever protection policy for vulnerable people who are exposed, especially to sylvatic transmission. And we saw this in some of the countries where we had huge outbreaks in 2016. The lessons learned, really, COVID-19 necessitated rapid adaptation to assume safe implementation. So countries guided by WHO frameworks for decision-making and guidelines, and they are really, Uganda, for example, sourced PPEs from local suppliers and personal implication of the Ministry of Health, which we thought was a good practice. South Sudan overcame challenges for COVID, which had impacting on deployment of technical staff. The whole issue about integration of vaccination activities, I think we need to learn from there, so that moving forward, this really will be the way to go and to reduce its operational costs. And then rapid response using in-country vaccines contributed to outbreak control. So moving forward, we are just finalizing now. We have an operational plan for the regional implementation of the I framework. And again, it's still structured around those three objectives that I alluded to at the beginning of this slide. And we have articulated what we want as our outputs in terms of, for example, where everyone protected in high-risk areas, we really need to have vaccinate everybody, achieve at least 80% population vaccination coverage. And for introduction of the routine vaccination into routine programs, again, that's really an outcome that we need, and the key outputs have been stipulated, for example, to introduce yellow fever into routine immunization schedules where we still have to do it, so that we can protect every child through immunization and implement targeted local strategies to raise yellow fever vaccination coverage, especially at high-risk districts. In terms of risk assessment, again, we really need to be able to understand the reason why we are having a resurgence of epidemics, so that we can be able to deal with the causal factors and moving forward. On the second objective, we have also articulated our outcomes in terms of, and then the outputs for that. For example, protecting at-risk health workers. We want to conduct vaccination activities among those health workers. For international health regulations, I think we really need to be able to deal with capacity, to address the capacity issues for us to implement IHR with respect to yellow fever vaccination requirements at points of entry and major border crossings. I think some of the efforts that we've learned from EVD screening and now COVID, I think we should really maintain those staff, even hopefully if the pandemic ends, that some of these staff who are doing this work can just be maintained there to continue with yellow fever screening, and that we have supply so that people can get jabs on site if they're not vaccinated, but at their cost. There is a whole notion about urban centers, and I think this is a critical piece of our work. We first in 2019 huge urban outbreaks in Angola and the DRC, and we really need to have this. So we want high-risk countries that they have readiness plans for all the urban areas, so that we have readiness plans for the urban areas, and that once those plans are there, we make sure that we review periodically to see the implementation and the achievement of the implementation of the readiness plans. And the final one is really no sustained transmission of yellow fever. I mean, this really is something by 2026, so that's our ultimate target. We need to be able to have rapid detection capacity as an outcome, and also outbreak response capabilities. Really, we must make sure that in all the countries, we really want to have case-based surveillance systems. We want to provide sample transportation in a timely manner so that samples can be referred from wherever we are getting cases to the reference laboratory labs, and then provide technical support and guidance to all the 27 to conduct national and subnational training for rapid response teams. Here, really, our rapid response team is based on integrated disease surveillance, but we add a module where we can focus on a few diseases. We've done this previously. We focus on COVID, yellow fever, sometimes Ebola, depending on the context. So this is really what we will do. We do a more integrated rapid response team training, but we tease out and do a module on one of the priority diseases. And then knowledge capabilities for yellow fever to strengthen this across the 27 countries. Later in the years when we think we have really dealt with some of this, we really want to start thinking about pilot implementation of yellow fever surveillance in non-human primates, and maybe sometime in the years to come, when we really know that administrative coverage for vaccination has gone up, we really want to be able to know, are we moving towards the target where we can say the seroprevalence, I mean, in terms of immunization of are we moving towards a herd of people who are now immune in the population. So to sum up, really, the successful implementation of the regional operational plan will depend on a couple of things. One, we really need to continue member states' engagement. Political will is very critical. And so we have to continue that, our governing bodies at the regional committee, at the World Health Assembly. But also I think when we need to align and have effective partnerships including from the private sector and civil society, to bring together all available resources. And I think the three levels of the organization, the countries, the regions, and our headquarters secretariat, we really need to be making sure that we work in a synergistic way. We've really been doing that. So hopefully that this is really working, and we have to maintain that. We need some kind of synergy in terms of our collaboration with partners. We have strategic partnerships with UNICEF, CDC, PATH, Gavi. I think we need to continue that. And I think this partnership forum is really good for us to see they are the traditional partners, but maybe in the coming years, we might be needing some new partners so that we strengthen the support that we offer to member states. We are going to be doing integrated surveillance through vaccine preventable disease surveillance system, but also just to let you know that we are reimagining our integrated surveillance and response to boost our outbreak detection systems. We are calling this a flagship program, where we know IDSR has been working with us since 1998, but we need to reimagine it, starting to use digital tools, ensuring that event-based surveillance and community surveillance is really, really well implemented. And then integration of the implementation of the PMVCs, preventive vaccination, probably with measles and MenA as well. And as I've alluded to this earlier, we really need to improve yellow fever international health regulations, compliance, and really this is one of the areas that I lead in preparedness. And at the moment, we're really looking at our border health, port health strategies, which is part of our other flagship program on promoting resilience of health systems for emergencies. So we hope that within this context of promoting resilience of health systems for emergencies in our border strategy, we'll be able to do that. And as WHO will continue to provide technical guidance to countries and also to monitor the implementation of the plans from the countries. Madam Moderator, I think that is the end of my presentation. I want to thank you for giving us the opportunity to present.
Thank you, Dr. Talisuna. I should note, colleagues, that Dr. Talisuna is another one of our guests on the podcast. So yet one more reason to have a listen to the podcast. Thank you for your presentation. We have a question from before, but I think it's appropriate for you. It's from Zorto Duamo Philip, who says, greetings and thank you for all the excellent presentations. In addition to the yellow fever preparedness tool in the pipeline, are there tools available that can be used to guide nations to conduct yellow fever hotspot mapping or risk assessment to find out where the yellow fever districts would be for intensive interventions, or I suppose even prevention focused efforts as well? Over to you.
Thanks, Nika. There are tools, yes, but we have experience from dealing with hotspot mapping in the context of polio. So I think even where tools are not there, there are adaptations. For example, I was talking about readiness mapping. We have quite a wealth of experience in readiness mapping, readiness planning when we, for example, have, say, a viral hemorrhagic disease in one country, and we make sure that the neighboring countries or the non-affected provinces are ready. So our experience in dealing with outbreaks, I think there are tools that we can use for that. And I think moving forward also, in the context of this, especially urban outbreaks, I think for me that the hugest outbreaks that we've got in the recent past have been around urban areas. And so we really need to be doing that for our urban areas to make sure that we deal with urban outbreaks. Over to you, Nika.
Thank you. And one of the things in your presentation caught my eye when you said looking further ahead, you would also look at some surveillance in non-human primates. Can you just talk a little bit about that? I know you said it's much further ahead, but very, very roughly what you'd be thinking of.
I think ultimately, when we talk about, I think the context is we're talking about elimination of yellow fever epidemics, but I think you really have to be looking at some of the other potential reservoirs where you could have maintaining transmission. So this is really something, it's not really in a like short term, but I think as we really make sure that our work plan is covered for some of the things, we need to be shifting. Could be work that we work with research groups or whatever to be able to start this on a small pilot basis to be able to see whether we are understanding what is happening in non-human primates, because they could be the reservoir for us to continue sustaining the transmission. So at some stage we need to do that. For the seroprevalence surveys, as you know, I really think, and when I was discussing with my colleagues here at the regional level, I was like, they wanted us to do it slightly earlier, and we were like, you know, I think at the moment we can use admin data. We know the coverage, we know probably, but as we increase the vaccination coverage, we need to be doing some of those seroprevalence surveys. So those are two things that we want to do. So understanding what is happening in non-human primates could be helping us, especially as we increase vaccination and we think that we are moving towards some kind of level of herd immunity. Then we need to see where the reservoirs, what is maintained in the reservoir of transmission in the population.
Thank you. Thank you very much for your time today and that overview of what our colleagues are planning in the African region. So we move on to the last half of our last session today, where we're going to be looking at the situation in Paro. This next session will be in Spanish. So my reminder again to look at the bottom of your screen where the globe icon is and choose the language of interpretation that you wish to have. We have one or two colleagues, I'm not sure whether we will have both today. We have with us, we have Dr. Jairo Mendez from the Pan American Health Organization, and also Alba Maria Ropero, maybe. But Dr. Mendez will take us through the epidemiological and immunization update for Latin America and the Caribbean. Over to you, s'il vous plaît.
Okay, thank you very much. Yes, I'm taking advantage of the interpretation. We're going to present in Spanish. So thank you very much. Sí, en nombre del doctor Silvana Dilleri, director adjunto del Departamento de Emergencias de OPS, quiero también agradecer a la Secretaría de la Estrategia AI por la invitación y la oportunidad de presentar esta actualización sobre fiebre amarilla en las Américas. Presento, como ya se mencionó, también en nombre de mis colegas, la doctora Alba María Ropero Álvarez, asesora regional de inmunizaciones, y Yamila Romer, consultora internacional. La doctora Alba María Ropero se encuentra en este momento en otra reunión. Ella va a tratar de unirse un poco más adelante para la parte de inmunizaciones. En caso de que no pueda, yo voy a hacer la presentación, y ella esperamos que se una también para responder alguna pregunta que pueda haber. Voy a presentar entonces y nos vamos a enfocar principalmente en la presentación de aquellos países en la región de las Américas en donde hemos tenido actividad de fiebre amarilla durante los últimos 2 años principalmente. Quiero empezar por Brasil, con el periodo de monitoreo más reciente que se comprende entre julio del 2020 y junio del 2021. Para este periodo, un total de 290 casos sospechosos de fiebre amarilla fueron reportados. De estos, 8 fueron confirmados y el resto fueron descartados o se encuentran aún en investigación. Es importante mencionar que los 8 casos confirmados de fiebre amarilla corresponden a personas que no estaban vacunadas, y todos ellos fueron identificados en algunas municipalidades, algunas ciudades del estado de Santa Catarina. Otros estados en donde se reportaron algunos números relativamente altos de casos sospechosos pero no confirmados fue en los estados de Sao Paulo, también en Santa Catarina, en Paraná, Goiás y en Minas Gerais. En términos, solamente para mencionar precisamente que la actividad más importante en este periodo ha sido precisamente en Santa Catarina. Ustedes ven acá precisamente hacia el sur de Brasil, sería esta parte del mapa. Ustedes pueden ver acá, y se alcanza a ver tal vez en rojo, en rojo se alcanza a ver los casos confirmados, casos humanos confirmados. En este caso, se cuenta entonces del total de casos en Santa Catarina, fueron 54 sospechosos y como ya mencionamos, los 8 que se han confirmado en ese periodo fueron precisamente en este estado. Importante mencionar que la cobertura de vacuna para fiebre amarilla en ese estado para este periodo fue de 76.74%. Lo que ustedes ven en verde es la presencia de epizootias. Y precisamente entonces quiero comentar respecto al tema de las epizootias en primates no humanos, también para ese mismo periodo de monitoreo hasta junio del 2021. Más o menos 1.449 epizootias en primates no humanos fueron reportadas como sospechosas. De estas, 218 fueron confirmadas y las demás se encuentran, algunas fueron no determinadas porque no se contó con una muestra, otras fueron descartadas o se encuentran en investigación. Es importante mencionar que, como lo veíamos un poco acá, la distribución de las epizootias ha ocurrido en algunos de estos sitios donde ustedes pueden ver acá un poco más en verde, que corresponde a la región del medio oeste de Brasil, que comprende los distritos de los estados del Distrito Federal y Goiás, el sureste, la región sureste en Sao Paulo, la región sur, principalmente en Paraná, en Santa Catarina, y la región norte en Acre. Entonces ustedes ven acá la distribución de los 7 estados que han reportado epizootias confirmadas de primates no humanos. La detección de epizootias en Brasil y en general en la región de las Américas es una de las actividades más importantes que nos permiten precisamente anticipar y la presencia y la actividad de fiebre amarilla. Para este periodo, el actual periodo de monitoreamiento en Brasil, que comprende julio 2021 a junio del 2022, se han reportado un total de 17 casos sospechosos de fiebre amarilla en humanos. De estos, 1 fue confirmado en el estado de Pará y 14 han sido descartados y 2 permanecen en investigación. En este mismo sentido y para este periodo, 198 episodios han sido reportadas en primates no humanos. Principalmente de estas 10 han sido confirmadas en Minas Gerais, en Río Grande do Sul y en el estado de Santa Catarina, donde se concentran entonces la mayor cantidad de episodios que han sido confirmadas hasta el momento. Vemos entonces que el número de casos reportados en el periodo entre 2020 y 2021 realmente ha sido significativamente más bajo del total que se ha observado en los periodos previos y que por supuesto se ha visto, y ustedes lo pueden ver acá, después de haber tenido 2 años prácticamente epidémicos en Brasil, en este momento los números son significativamente mucho más bajos. Otro país en donde hemos tenido la actividad de fiebre amarilla es en Perú, que para la semana 38 habían notificado 17 casos sospechosos de fiebre amarilla. De estos 17 casos, 10 han sido confirmados y 7 permanecen como probables. De los casos sospechosos, el 85% corresponde a sexo masculino. El 43% ha sido identificado en adultos jóvenes entre 18 y 57 años y de esos ninguno contaba con historia de vacunación. De estos 7 casos fatales, 7 muertes han habido que han sido reportadas en los departamentos de Puno, San Martín y Loreto. Solo para resumir, durante los últimos 6 años, un total de 111 casos de fiebre amarilla, incluyendo 41 muertes, han sido reportadas en Perú y de estas 103 han sido confirmadas con el resto clasificadas como probables. Y la situación más reciente de actividad de fiebre amarilla confirmada ha sido en Venezuela, en donde se han detectado algunos casos humanos. Esto ocurrió para la semana epidemiológica 39 de este año, 2021, con un total de 7 casos de fiebre amarilla que fueron reportados y confirmados por métodos moleculares, por PCR, en el Instituto de Higiene Rafael Rangel que es el Instituto de Referencia Nacional y el Laboratorio de Referencia Nacional para el diagnóstico de fiebre amarilla. De estos casos, 3 fueron asintomáticos, 4 desarrollaron síntomas y signos durante la semana epidemiológica 38. El sitio probable de infección de estos casos confirmados fue la localidad de Carapal, una parroquia rural que se encuentra al sur de la ciudad de Maturín, acá en el estado de Monagas. Maturín es de hecho la capital del estado de Monagas en Venezuela, que ustedes pueden ver acá en esta parte del mapa. El primer caso reportado fue una niña de 16 años que se encontraba embarazada con historia de vacunación y que de hecho tuvo un aborto, y en ese mismo día fue cuando se hizo la detección de fiebre amarilla. Los siguientes 6 casos son, de hecho son 5, son de sexo masculino, con edades entre 24 y 82 años y sin historia de vacunación. Hasta el momento no se ha registrado ninguna muerte entre los casos confirmados. En términos de epizootias que también se han investigado, importante mencionar que a la semana 32 epidemiológica, entre las semanas 32 y 39, un total de 10 epizootias entre primates no humanos fue reportada en Venezuela. De estas 7 se han encontrado precisamente acá en el estado de Monagas y 3 en el estado fronterizo en Anzoátegui, que es el estado fronterizo y es en donde se han visto precisamente las epizootias. 2 de estas epizootias en Monagas fueron confirmadas por laboratorio y 8 fueron confirmadas por nexos epidemiológicos. Las epizootias que han sido confirmadas fueron identificadas alrededor de entre 35 y 150 kilómetros del área urbana, precisamente acá de Maturín, capital de Monagas. Simplemente para terminar esta parte de la vigilancia epidemiológica, mencionar que en cuanto al trabajo en laboratorio se ha mantenido y solo mencionar que para la región de las Américas se toma la vigilancia, existe una red regional de vigilancia por laboratorio de arbovirus, que es la RELDA. Para esta red tenemos 30 laboratorios en 26 países y todos ellos cuentan con la capacidad para detección molecular de por lo menos 4 arbovirus: dengue, chikungunya, zika y fiebre amarilla, por supuesto. Y también tenemos entonces implementada la detección y el diagnóstico serológico, principalmente enfocados en los países que son endémicos para fiebre amarilla. Entonces, solo para mencionar una de nuestras fortalezas en la región, que es precisamente la capacidad de laboratorio, y que seguimos trabajando en conjunto con nuestros centros colaboradores, que ya tenemos en este momento 5 en la región: el INDRE en México, el Instituto Nacional de Enfermedades Virales y Hemorrágicas en Argentina, el IPK en Cuba, por supuesto nuestros colegas del CDC en Fort Collins, y próximamente vamos a tener la delegación del Instituto Evandro Chagas en Brasil como centro colaborador también para arbovirus. Simplemente algunos comentarios de esta primera parte. La actividad de fiebre amarilla entonces permanece relativamente baja para el periodo 2020-2021, con adicional a lo que mencionamos, un caso en primates no humanos también fue detectado en Trinidad y Tobago, y ahí ha habido señales adicionales, algunas señales adicionales en Panamá. Por supuesto, la emergencia actual debido al coronavirus ha afectado las actividades de vacunación y por supuesto también las actividades de vigilancia, principalmente en algunos sitios en donde nos hemos enfocado, por supuesto, en COVID-19. En este momento se ha comenzado entonces el periodo de fiebre amarilla en la mayoría de los países, y aún así, por supuesto, el cuidado hospitalario está enfocado a la alta demanda que todavía tenemos de COVID-19. Seguramente ha habido una reducción en la inmunización en algunos estados en Brasil, y ahora más adelante lo vamos a ver en la parte de inmunizaciones. Sin embargo, OPS mantiene una comunicación constante y regular con todos los países para asegurar que se mantengan las actividades de vigilancia de fiebre amarilla, y dentro de eso está precisamente el fortalecimiento de las redes de laboratorio distribuyendo material y actualizando permanentemente con nuestros colegas del CDC de Fort Collins. Me parece que la doctora Alba María Ropero está ya presente y disponible. Entonces, Alba María, si tú quieres seguir adelante, yo te puedo pasar las diapositivas.
Bueno, muchísimas gracias. Buenas tardes y gracias, Jairo. Y ya estoy de regreso, disculpen. Bueno, aprovechando que tenemos traducción al español, es un placer hacer esta presentación en español para ustedes. Por favor, Jairo. En esta diapositiva podemos ver las coberturas de vacunación en los niños a un año de edad en las Américas desde el 2017 al 2020. Y quisiera llamar la atención para ustedes el descenso de coberturas en los diferentes países con estas coberturas de vacunación en varios países y otros países que tienen algún buen desempeño como Trinidad y Tobago y Guyana y Panamá, pero en Panamá también hubo un descenso. La siguiente. Aquí tenemos entonces en los últimos 10 años un promedio, el promedio de la vacunación, el promedio de cobertura de vacunación entre un 75 y un 81%. Ha habido un descenso el año pasado, en el 20 hubo un descenso de 7% de la cobertura de vacunación y también ha habido un descenso de la cobertura con triple viral con sarampión rubéola en el 2020. Aquí en la parte inferior de la gráfica vemos un heat map donde vemos las coberturas y desde el 2010 al 2020 y una variabilidad importante en los países con relación dentro del mismo país a través de los años, cómo fluctúan las coberturas de vacunación. La siguiente, Jairo, gracias. Y en esta diapositiva podemos ver las brechas de fiebre amarilla en comparación con triple viral. Tenemos un indicador de que sean las coberturas por debajo del 5%. Aquí tenemos gran parte de los países con brechas inferiores al 5%, pero vemos otros países como Guyana, Colombia y Panamá que están entre el 5 y el 10. Y es más importante en este momento la brecha de dos países como son Brasil y Perú, que tenemos una brecha casi de un 20% en comparación de triple viral y fiebre amarilla. Y ustedes saben la acumulación importante que eso implica de susceptibles a través de los años. La siguiente, Jairo, por favor. En esta diapositiva vemos la solicitud de vacunas al fondo rotatorio y lo que se ha provisto a través de los años, la demanda en azul y el supply en naranjado y en gris la oferta que ellos recibieron. Quisiera llamar la atención que ha habido desde el 2019 y 20 ha habido una mayor oferta en comparación a lo que siempre reportábamos estos años de las dificultades y la limitada disponibilidad de vacuna. O sea, podemos decir que ha habido una mejor oferta estos 2 años, pero hubo, por ejemplo, 20 y 21 sobre todo tenemos una menor demanda de vacunación. Lo sabemos porque esto está muy relacionado con la pandemia de COVID-19. Muchas gracias. La siguiente. Aquí quisiera recordar simplemente que tenemos en la OPS unas recomendaciones muy fuertes del Grupo Técnico Asesor de Inmunizaciones sobre la importancia de coadministrar la vacuna de fiebre amarilla con la de triple viral, con el fin de aprovechar la oportunidad de las mejores coberturas que tiene triple viral, que sarampión está en proceso de eliminación, que los países están haciendo grandes esfuerzos para mantener altas coberturas, y fiebre amarilla en los municipios que coincide, que son en zoóticos para fiebre amarilla, debe aprovecharse esta oportunidad para hacer una actualización, para poder incrementar las coberturas. En este mapa tenemos acá 2 países que el impacto de la pandemia, los países que pospusieron las campañas de vacunación, Bolivia y Colombia pospusieron estas campañas y en este año 2021, afortunadamente con las campañas que están haciendo de sarampión y rubéola, entonces pudieron integrar fiebre amarilla en los municipios de riesgo. Aún así no tenemos la campaña, las fechas de campañas nacionales que están planificadas, no las tenemos todavía. La siguiente. Y acá quisiera llegar a la situación de Venezuela, a hacer énfasis en la situación de Venezuela, que como ya hemos mencionado en otras reuniones, Venezuela el año pasado recibió una donación importante de vacunas de más de 4.700.000 dosis de Brasil. Se hizo un plan para vacunación en las áreas de riesgo, se avanzó de manera importante en coberturas en estos departamentos de riesgo, pero ahora estamos enfrentando un brote, como ya lo presentó Jairo, y se requiere intensificar la vacunación, especialmente en los municipios de riesgo, y completar la vacunación, cerrar brechas en los 10 municipios de riesgo. La siguiente, por favor. Bueno, aquí tenemos otras actividades para comentarles que estamos haciendo una encuesta en la región para actualizar la situación de políticas, de planes, actividades, incluyendo vigilancia. Y se está haciendo con una metodología online que es muy amigable. La siguiente. También estamos trabajando en el roadmap alineado con el AI Strategy para tener unas coberturas altas para cerrar brechas de vacunación en la población adulta y reducir riesgos de transmisión de fiebre amarilla en la región. La siguiente. Como conclusiones, entonces tenemos que la pandemia ha afectado de manera importante las actividades de vacunación. Ha habido un descenso en las coberturas de vacunación y también un descenso en la demanda de la vacunación. Es importante entonces fortalecer y aprovechar las diferentes campañas y diferentes oportunidades para integrar fiebre amarilla con todas las demás actividades de vacunación. Y estamos en el proceso de actualización del plan de vacunación. Y con relación a Venezuela, quiero finalizar acá aprovechando este contexto global y mencionar, hacer abogacía sobre la situación de Venezuela. Las vacunas que ya recibieron el año pasado se aplicaron, ahora no tienen más de 200,000 dosis, de las cuales se vencen ahorita en octubre. Y las están aplicando, pero no son suficientes para cerrar la brecha y están pidiendo aproximadamente 1 millón de dosis de vacuna. Tienen una solicitud del fondo rotatorio, pero no tienen recursos para comprar estas vacunas. Entonces, aquí en este foro global, quisiera hacer un llamado porque es importante cerrar controlar este brote y apoyar a Venezuela, que tiene áreas de riesgo, como sabemos, con epizootias en varias áreas ampliadas de las zonas de riesgo. Entonces, Venezuela está solicitando en este momento aproximadamente 900,000 dosis que no tiene, por supuesto, las jeringas y recursos para costos operativos. Entonces, quiero aprovechar esta oportunidad para traer a este foro esta situación especial de Venezuela en la región. Con esto quiero terminar. Muchísimas gracias.
Gracias a ustedes. I also wanted to thank our interpreters. I believe we're at the top of the hour, and we've booked our services just until now, so we'll be losing our interpreters now, I think. So we might ask you for the questions now, if you could answer briefly and do it in both Spanish and English, if possible. That would be much appreciated. So we have one question for you, Dr. Mendez, in the Q&A section. It's from William Komakek, who says, thank you very much, Jairo, for your presentation. Could you please explain a little bit more about how yellow fever surveillance is conducted in non-human primates in the Americas? Over to you.
Thank you very much for the question. Actually, the surveillance here in our region, particularly in those countries which are endemic countries, we have 13 endemic countries. And for several years, we have been working with them to expand the capacities and developing guidelines for the early detection and the active surveillance of, for instance, to look for dead bodies or dead monkeys in different areas, sylvatic areas, of course, in areas where for the people to be aware or of this kind of episode that may happen, and to inform the public health specialists to go to collect, for instance, the bodies or the bodies of the monkeys. And after that, most of the laboratories actually in the region has the capacity to detect, for instance, in tissue samples from the monkeys to see if there are some activity of yellow fever. Of course, it's not the same in all the countries. We are trying to implement and to reinforce this surveillance in most of the countries. There are many countries like Panama, for instance, where they are very active surveillance also in non-human primates, taking additional samples very routinely to see if they have antibodies for yellow fever and to detect if there is some sort of activity in some regions. Again, something that we are trying to reinforce and to strengthen in the region. And thank you for that question.
And thank you for the answer. So a question for you, Alba Maria Ropero. You spoke, Dr. Mendez mentioned, and you did as well, the impact of COVID on yellow fever vaccination, mentioning that the attention has been pulled away, the human resources are moved elsewhere. But in the presentations earlier today, a few colleagues mentioned as well that some of the vaccine hesitancy has confused people. They think when they go for a yellow fever vaccination, they think it's a COVID vaccine and they're not so sure, they're confident. Have you seen the same thing in the Americas as well?
We have seen a decline on the vaccine and the routine immunization in general. That has been a huge impact of the routine immunization. Around 20% difference for many vaccines, and especially with the measles, rubella, and also with Penta, which are key tracers for us in the routine immunization. And of course, this is worse with yellow fever. And we are doing that evaluation right now with our survey in 2 countries, and we'll have better information soon. I hope that we can share that. Regarding the misinformation with yellow fever, I haven't heard about it. We have the issue that we need to offer the vaccine. We did something that was very nice last year, that was to emphasize during the pandemic that even in the context of pandemic, vaccines should be offered, such as yellow fever, those vaccines that are or diseases prone to outbreaks, such as yellow fever, measles, and influenza as well. And then we highlighted a lot that in the vaccination week of the Americas, and then we promoted the vaccination in the yellow fever vaccination. And actually that was very good because as I mentioned, campaigns were postponed, and then trying to take advantage of any opportunity to include yellow fever, that was good. But still we are below the level that we need to be. And then that's important to strengthen the routine immunization and also and at some moment to restart the campaigns in the region.
I guess a question for both of you as we wrap up. It's our last question today. We're already out of time, but just wanted to ask you both one more question. How does the I strategy, and especially the partners, how does that help in your work against yellow fever? How is it helpful to have this strategy in the region?
I can start and Jairo can complement. The I strategy has been very useful for us in the region to highlight and give visibility to yellow fever. We mentioned in some forums that before I strategy, yellow fever was a little neglected. And then this strategy put the yellow fever on a high visibility and visible platform. And that has been very useful. And also getting vaccines in the worst time that we didn't have much access to vaccines was in 2016-17, and I strategy helped us with UNICEF and others, and we got vaccines. And also we are working in alignment with our regional plans and our roadmap that is of course in alignment with the global I strategy, and then we need to join efforts. And the last point that I mentioned with Venezuela, for example, if we are able also to support critical countries or key countries in the region, such Venezuela in that situation, that will be important. We haven't had any specific support for Gavi countries because they already manage the budget, and Gavi countries that now are graduated, they are former Gavi countries, for example, Bolivia or Guyana, they have the money. But in this case, Venezuela is not a Gavi country, but this is a very fragile country at this moment. And then having this platform and having this call for action in order to support a key country will be important. Thank you. Jairo, over to you.
Thank you. Maybe just to mention in addition that actually for us, it's been very critical, the work, particularly with the laboratory working group. I'm a little biased, of course, because I'm a virologist. So But working together has been really critical, and to not only to learn about what has been happening in other countries, but also because the close relationship, particularly with the CDC in Fort Collins, has allowed us to reinforce and to really improve the capacities for laboratory detection in the whole region, and that being critical with the reagent, the material, and the trainings that we have done here in the region. So actually the work with the laboratory working group is being critical for us also here in the region. So thank you for that, actually. Thank you.
Thank you. So those are nice words to finish on, right? Obviously, it's very inspiring for the partners to hear how helpful their work is and how it's sustaining you as well. So this brings us to the end of our session, our first day of the 3-day meeting, of the 5th meeting of the iStrategy Partners. We hope you've enjoyed day 1. And look forward to seeing you again tomorrow and the next day. We'll have different colleagues moderating on the next 2 days. Tomorrow it will be Priyanka Khanna, who's an advocacy and communication specialist from UNICEF. Thank you again to our interpreters. Thank you all for listening in. We had between 150 and 160 people listening throughout the day, a sustained 150 through to the end. So thank you. Enjoy the rest of your morning, afternoon, or evening, and look forward to seeing you again, welcoming you back again tomorrow. Bye-bye.
Thank you. Bye-bye.
Thank you all very much.